Hi, Kim. Can we do a mic check, please?
Good afternoon. Can you hear me?
Yes, thank you.
Thank you.
Michelle, can we do a mic check with you, please?
Hi, good afternoon.
Hello, thank you.
Good afternoon, this is the clerk. We are now live on the meeting portal and YouTube.
Hello, Fawn, can we do a mic check, please?
Hi, yes, hello, good afternoon.
Hello, good afternoon, thank you. Jackie, can we do a mic check with you, please? Jackie, if you can hear me, can we do a mic check, please?
Yes, good afternoon. This
Good
is
afternoon.
Jackie.
Thank you. Hi, Doug, can we do a mic check, please?
Yeah, hi Dave, can you hear me okay?
Yes, we can hear you. Thanks very much.
Great, thank you.
Hello, Yvonne, can we do a mic check, please?
Yes, good afternoon.
Good afternoon, thank you.
Thank you.
Laura, can we do a mic check with you, please?
Can you hear me now?
I can, yes,
Rosa.
thank you.
Great, thank you.
Hi, Doug, can we do a mic check, please? Doug Koenig?
Okay, how about this?
Yes, we can hear you, thanks.
Thank you.
Hello, Supervisor Simidian.
Hello, is this Nancy Guerrero?
It sure is.
Well, let's do our mic check then. Nancy, how we doing?
We're doing great, thank you. How about yourself?
I think we're fine. Everything's loud and clear at my end. Thank you to you and the team for your help today.
It's our pleasure.
All right, we are about 1 minute away, I think.
Yes, that's correct.
All right. And Supervisor Lee is with us or almost with us?
He is here.
Great.
Good afternoon, Chair.
Good afternoon, Vice Chair. So there you go. All right, the hour of
Recording in
1:30.
progress.
Oh, my apologies.
Go right ahead. Thank you all very much. The hour of 1:30 having arrived, we will ask the clerk to help us with item number 1, which is the call to order, and that starts with a roll call to establish a presence of a quorum.
Vice Chairperson Lee
Present. Good afternoon.
and Chairperson Simidian.
Here. All right. Thank you very much. Madam Clerk, we have a quorum. Both members of the committee are present and accounted for. That takes us to item number 2, which is public comment. And public comment, and I would ask that folks listen carefully. Public comment is that portion of our agenda set aside for non-agendized items. Again, those are items that are not on our agenda. And if you want to comment on a non-agendized item that is properly within the jurisdiction of our committee, this is the time. And if you are here to comment on one of the other items on the agenda, those items being 3 through 12, let me ask that you communicate with us then at that time. We do not allow public comment to essentially be duplicative of comments that are on agendized items later on in the agenda. And let me ask the clerk to assess how many folks do we have who would like to speak under public comment, if any?
We have one member of the public that wishes to speak. Oh, we now have 2.
All right, let's let those 2 folks each have 3 minutes, consistent with the rules of the board. And if we get more, we will have to cut it off at 5 since we are allowing 3 minutes. Go right ahead.
Okay, our first speaker is Scott Largent. I am unmuting you. Please accept the unmute and you will have 3 minutes to speak. The timer will start when you begin speaking.
Thank you, everyone. Scott Largent. I do get kind of spotty cell reception, so I do apologize if the phone call starts to break up a little bit. I had problems at the last couple of meetings. So what I'd like to talk about today, I try to stay in my lane on a lot of these issues, so I can wait till the behavioral health item comes up along with our psych ward, including the other reports back from behavioral health. You guys know how I feel about that system, and I can address those when those items come up. There is one a disturbing situation that happened last night. I was over on Monterey Highway. I go grocery shopping over at the Walmart over there. It's the best prices for getting food and stuff like that. A woman was out in front between the Big Five, Sporting Good, and Walmart. African-American woman, completely naked, screaming and yelling and throwing things around. It's a constant thing that I see almost at every different large complex now. I was very concerned for this woman, and what I'll do is when we come up onto that item, I'll discuss this more into detail. It was just shocking. I'm still can't quite get over what I got to see yesterday, including the small children that got to see it. It's very shocking. The woman should have gotten dignified help and pulled out of that situation. My big thing today is trying to find a place to put motorhomes, safe parking programs. And Joe, you're very familiar with this. You pop up in a lot of different articles in regards to what happened in Palo Alto and what was set up in place with Amigos del Guadalupe. I believe originally it was 8 slots, then it was increased to 36 slots, and that place maxed out in about a week. The other safe parking programs are basically all being shut down. I called through the shelter hotline several different times. Can't get a solid out of them. Then they tell me about a location off of Cottle Road, which was pretty much a rec center for the city of San Jose that discontinued that safe parking program. The other one that's next to Roosevelt Park, same thing. It's been shut down. It's non-functioning. The people right now that live where I live in the crash zone near the airport are not going to have a chance at all. The cities have put up so much signage around here. Basically, when they get swept from this field, their vehicles will be immediately towed. They will no longer have shelter. They will be in tents. They will be in the creek. This is not going to go away. And I'm still wondering why we're not helping getting people's vehicles running, getting them registered, and just giving them a place to park. In my situation, I would pay rent. I would pay anywhere from $500 to $1,000 a month to park my RV, continue to work, continue to be sober, and be in my daughter's life. I just need something like that. And so do all these other people. So I hope you guys are paying attention. Thank you.
Our next speaker is Tino. I am unmuting you. Please accept the unmute and you will have 3 minutes to speak. The timer will start when you begin speaking.
Okay, this is going to be real quick. I'd rather have time on actual agenda items, but I just wanted to say, Joseph Samidian, it was a pleasure meeting you at the farmers market this past Sunday. It was nice to be able to speak to you face to face. I did send you several emails this morning, and I do plan on following up with some additional emails with very detailed information. So I hope that you received it, and I look forward to talking later on some very specific agenda items. Thank you.
That
Thank
concludes
you.
our public comment.
Thank you, Madam Clerk. And that takes us then to item number 3. And item number 3, of course, is the approval for the consent calendar and changes, if any, to the committee agenda. Supervisor Lee, if you are amenable, the chair would gratefully entertain a motion to approve the agenda order and the consent calendar is published, but with the addition of items 9, 10, and 11 added to consent. 9 is the Mountain View Specialty Clinic and Pharmacy, 10 is the Subsidized Medications Pilot Program, and 11 is the Health Equity Agenda. All important issues, but issues that I think we can handle on consent today, given the pressing demands for time associated with other items. Would that be amenable to you, sir?
Yes, Chair, and so moved.
All right, we have a motion by Supervisor Lee and a second by Supervisor Samidian. That would be me. Let me check with the clerk of the board to see if we have any comments from the public on the consent calendar items as now agendized.
We currently have 2 speakers.
Let's go ahead and hear from those 2 speakers, each of whom will have up to 2 minutes pursuant to the rules of the board.
Thank you. Our first speaker is Ken Horowitz. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Thank you. This is Dr. Ken Horowitz of the Health Advisory Commission, and I'm speaking on agenda item number 11, which involves this approval of the monies for a health equity plan. I would like to ask that the Health Advisory Commission be included in this steering committee. The Health Advisory Commission is currently involved in bringing awareness of functional medicine to the county's health and hospital system. Functional medicine deals with the root causes of disease, and by doing so, our hope is to transform the way medicine is being practiced currently and transforming it from disease management to really true healthcare. As you often quote Walter Cronkite's definition of healthcare, I believe that we need to transform our practice of medicine in the county. And as a result, I would like to ask that the Health Advisory Commission be involved in this steering committee. Thank you for your time.
Thank you.
Our
Next speaker, please.
Yes, our next speaker is Mike Rogers. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, this is Mike Rogers. I'm speaking to the same agenda item that Dr. Ken just spoke to. I submitted a 1-page summary on this. It went into a little more detail. I asked that people take a look at that. I strongly agree with Ken that this get referred to their commission as well. I'm very interested and have a lot of experience in functional medicine and telehealth myself personally on the technology side. One description of functional medicine is treat the root cause of disease, not the symptoms. 2/3 to 4/5 of all medical costs are tied up in non-communicable diseases. The top chronic conditions are a spectrum of metabolic syndrome related diseases, type 2 diabetes, obesity, non-alcoholic fatty liver disease, which may affect as many as 70 million Americans, hypertension, congestive heart failure, etc. All of these are epidemic levels and rising, especially in pediatrics, but also higher in minorities and people of color and lesser served communities or by an income basis. Integrative nutrition is a branch application of functional medicine that approaches nutrition from an evidence-based metabolic basis rather than traditional caloric and anti-fat basis of nutritional guidance traditionally over the last 30 years. It's a relative new science, but has incredibly effective results, evidence-based results across pediatrics, across other different demographics. Dr. Robert Lustig, UCSF, famous endocrinologist, had tremendous success. There's a startup that's engaged with at least one school district in the district. The Morgan Hill High School District is engaged with this startup. And, you know, his description of this is really good. It says, these diseases are completely reversible if addressed early enough, but not by symptomatic medication, rather by nutrition and by food. Thank you for your time.
And that concludes our public comment.
Thank you very much. Thank you both, gentlemen. That completes public comment. And the report we have on item 11, to which these folks just spoke, comes to us from the Public Health Department. I don't know if Dr. Cody or one of her staff are on board, but if so, I'd like to just ask that you reach out to them and consider the request for engagement that they've provided us with today. Do we have someone from Public Health who can just unmute themselves and indicate message received?
Good afternoon, Supervisor. And this is Dr. Cody. I think one of the main points in this ledge file is that Public Health is not the convener. It's the community partners that are conveners. We are participants, but not the convener. So I think that that request would be passed along to Community Health Partnerships and the other partners.
Great. And if we can make sure that it gets shared with Supervisor Chavez's office, since she was an initiator of this effort, I'm guessing that these folks have already been in touch with her office, but it can't hurt to pass along the official word from the committee. So we'll ask that you share that with them as well. Thanks so much. All right.
Thank you.
That, as I say, takes care of items number 9, 10, and 11. And Supervisor Lee, we did get some inquiry about item number 7 and when it will be heard. That, of course, is the item in connection with our sexual assault forensic exam services and safe sites. I just wanted to indicate for staff, committee, and members of the public that the expectation is that we probably won't get to that until 2:30. And just to help people with their scheduling, I'll just indicate now that we will not take that item up prior to 2:30, notwithstanding what progress we do or don't make in the meantime on the rest of our agenda. So again, if you're interested in item number 7, we'll try to get to that as soon as possible after 2:30, but not before. Okay, we have a motion by Lee and a second by Simidian to approve the consent calendar and changes to the committee agenda. Could we ask the clerk to please call the roll?
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye.
Thank you.
Thank you. The measure carries unanimously. That takes us to item number 4, which is recommendations relating to medical staff and allied professionals at our health and hospital systems, as indicated in our published agenda, items A, B, C, and D. Under item 4, this is to ratify various appointments and reappointments and to approve the new enterprise-wide pulmonary critical care and sleep medicine privileges, as well as the general service, as well as the general surgery privileges, adding hand surgery for St. Louis Regional Hospital. So I think we have Dr. Kreines with us to provide any information. And Dr. Kreines, anything you would like to share with us as we go about the business of approving these appointments and privileges?
Thank you very much. I just wanted to take this opportunity on behalf of the medical staff to thank the Board of Supervisors and everyone else involved in the Stars and Strides run this past weekend for their support of healthcare workers in our county. It was greatly appreciated. And I'm here to present the reports you mentioned and answer any questions that you may have.
Thank you. I have no questions. Supervisor Lee, if you have questions, this would be the time. Otherwise, happy to entertain a motion for approval as contained in our published agenda.
Yes, I would like to echo Dr. Carana's comments, especially this this Sunday when we had our first run actually for a long time since our COVID shutdown back in March. It's great to see 1,500 people all coming out to support the VMC Foundation. I was able to bring my $2 out there, and I didn't do a very good time, but apparently somehow I still come in third among the elected officials, which that shows me that not enough of us are participating. So certainly want to get more of us come on next time. But it was a great fun day, and certainly raised some significant funds for our foundation. So thank you, Dr. Ramos, for bringing it up, and really an honor to be there. Thank you.
All right, do we have a motion to approve?
Yes, ready. Motion to approve, please.
Thank you. I will, of course, second, and let me check with the clerk. Do we have any speakers on this item?
We do not have any members of the public that wish to speak.
Then let's call the roll.
Vice Chairperson Lee
Aye.
and Chairperson Simidian.
Aye. Motion carries unanimously. Thanks again, Dr. Karanis, and please share our thanks with your staff.
Thank you.
That takes us to item number 5, and item number 5 is the Child and Adolescent Psychiatric Facility Report. This, of course, is a monthly report designed to help ensure that we stay on time and on track. Dr. Smith, who's going to present today? Is this Mr. Draper?
I think we're going to start with Doug Koenig.
Yes. I'll start off. Good afternoon, Supervisor Simidian, Supervisor Lee, Doug Koenig with FAF Capital Programs. As our report indicated, there are several issues ongoing now that are impacting our ability to hold the schedule. The first is the design review, the collaborative review with OSHPD of the incremental packages that we've been working on. OSHPD has recently advised us that for the second time, they are pushing back their projected date as to when they can approve the first increment, which is the foundation and the structure. So that right now that's looking like it's going to be the first week of November. So since from the original schedule, that's a slip of 6 or 7 weeks. The second issue is we don't have a demo permit yet for PS3. Because of that, we've not been able to issue the notice to proceed. The reason we don't have a demo permit was that county planning asked that before they review our demo permit submittal, they wanted to see the shoring design. The shoring design was a package that it's a delegated design package. The responsibility is with the CMR XL Construction. And they did not complete that until last week. Our design team has reviewed that, and they've since submitted it to the planning department, so to the building department, so that so now the submission is complete, and hopefully we can get a quick response from them. The third issue, and probably the biggest issue, is that our CMR XL Construction has told us that they cannot meet the November 2023 date. They've said that the best they can do is June of 2024. We've told them repeatedly that that's unacceptable, but as recently as this past Monday, they've issued a letter to us wherein they're standing firm saying that they can't do it any earlier than June 2024. Right now, we're continuing to work that issue with them. Are there any questions?
A boatload, but why don't we hold off for a moment and see if there are any speakers from the public on this item?
We currently have one speaker.
Let's go ahead and hear from that speaker, please.
Okay. Our
And again,
speaker.
Up to 2 minutes. Thank you. Excuse me, Madam Clerk.
Thank you. My apologies for interrupting. Our speaker is Scott Largent. I'm unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
Good afternoon, everyone. Scott Largent. It might have kind of choppy reception right here, so I do apologize. Looks like we're going to have some delays right now. I'm looking forward to hearing what you're going to have to say about all this, Joe. I know you've been putting a lot of pressure on the construction companies and facilities and fleet to get this job done. We need this facility up and going. I'm very curious also what we're going to do with the existing psych ward. over there at Valley Medical, why it's not functioning properly right now and why they're running that thing into the toilet. I'm curious why people are not put on the proper holds right now, and they legitimately should be in there. So I understand the COVID thing and stockpiling people in locations, but a dignified place to be is not in traffic. It's not like that woman was out in front of the Walmart and the Big Five, naked and screaming and yelling, only to have the police show up, put her clothes back on, and let her go to the next complex to do the next thing. I'm very frustrated. You guys can probably get that by now. Why people are not put on holds. If this was one of your family members, you would want them pulled out of traffic. And setting a baseline for these people and saying that this is normal activity, this is not. I have watched these people for year after year, and watching their condition deteriorate. This is not right. And I cannot sit here and constantly watch this. I don't know why it really messes with my head. Because 6 years ago, I was one of those people that was screaming and yelling and doing that. And I just wish somebody would have stepped in. And I'm hoping you guys help these people. I'm sick of seeing them getting run over, and it's shocking when people see a naked woman screaming and yelling. How do you explain this to your kids? How do you explain this to the community? I'm shocked. Thank you.
That concludes our public comment.
Thank you. All right, let's go back to our board committee here, and to staff. I see that Dr. Smith, our county executive, has his hand raised. So before I offer question or comment, I'll turn to you, Dr. Smith.
Yes, I wanted to expand a little bit on the comments from staff about the scheduling. We are in discussions through county council and XL's attorneys about our disappointment with the schedule change, and we intend to proceed with a legal approach to compliance. I don't want to say too much more than that because it is got the potential for litigation, but want to assure the committee that we're pushing as hard as we possibly can, as many ways as we can, to get the timeline readjusted back to what was initially agreeable. In terms of the delay related to OSHPD, again, there's a push by us to try to get back on the same timeline that they agreed to. We don't actually have a legal recourse regarding that approach, but we will continue to push as hard as we can. So I'll be happy to take questions.
Thank you. Supervisor Lee, if you can bear with me for just a moment, let me pursue each one of these three items in turn. On the issue of our CMR, construction manager at risk, the folks at XL, did they have a due date for delivery in the contract that we have with them? And does that due date indicate fall of 2023 or summer of 2024?
November of 2023, sir.
All right. So a delivery 6 or 7 months hence would be inconsistent with the date that's contained in the contract. Is that correct?
Correct.
Yeah. Well, I'll just say as one member of the committee, Dr. Smith, I know I don't have to communicate to you the sense of urgency around this project. It has been many years in coming. And my expectation is that the contractor will perform as provided by contract. And if unfortunately that results in litigation, so be it. Always want to avoid litigation if we can, because that's not the goal. The goal is to get the project up and serving the public as quickly as possible, obviously. But you know, your team has to do what they have to do. And if the contractor is not prepared to honor the contractual commitment and litigation becomes necessary, I guess my reaction would be so be it. I am curious about the situation at Oshpod, in part because they have to date, as I have understood the reports from staff, in fact, gone out of their way to try and move things along and to be helpful and to take things sequentially. Do we have some sense of what the cause for concern is? And I'm asking in part because I saw a lack of resources mentioned. And of course, that's in the year when we've had the biggest surplus in California state history, to my knowledge. So I'm scratching my head, asking myself, how is lack of resources the problem? I suppose it's possible that the individual department has a lack of resources, but can somebody shed some light on the issue at Oshpod, please?
Basically,
Go ahead.
go ahead. I'm just going to, they believe that they overcommitted, that there are many other projects that are going on right now. Stanford has many projects that are in, and they've made commitments to them before we even got into the in line. We've got a lot of other projects ourselves, that are ongoing or under review at Oshpod. They're just saying they overcommitted themselves. They did the first adjustment of pushing everything back 1 month, and now they're saying that they're probably going to be another 2 weeks. So, but other than that, they've still been very supportive. We're making great progress. We think we've got a good design, but it's just they couldn't keep up with the schedule they committed to.
And then on the demolition permits, I understand that our planning department felt that they did not have what they needed to move forward. Do I understand correctly, Mr. Koenig, that they now have what they need to move forward with the issuance of permits?
We've not received any comments back yet, but we have provided everything that they've asked for.
Could we get an off-agenda report indicating how that process sits sometime within the next 2 weeks or sooner, if you have clarity from planning about what that process looks like? I want to make sure we don't lose a month while we're waiting for an answer to, do you have what you need?
Certainly.
Thank you. Dr. Smith, does that seem like a reasonable request?
Yes.
Yes, absolutely. We'll get it done.
Okay, thank you very much. I don't think I have any other comments today or questions. Please don't let my relatively brief inquiries and comments suggest anything other than the continued sense of urgency I feel for this project. I think it's taken us an awfully long time to get to this point, and I want to make sure that the momentum that I thought we had built up is maintained. And again, my expectation is that people who sign contracts will honor the contractual commitment. And if that requires aggressive litigation, so be it. Always prefer to avoid that if possible, but if that's what it takes, that's what it takes. Supervisor Lee, comments or questions from you? Thank you for your patience, sir.
Thank you, Chair. I think I voiced the similar sentiment issue that the need of this project is so urgent, and such delay that's been mentioned extremely disappointing. Before our break in June, certainly seems like everything is on track, and you've made it very clear, asking these questions over and over again, to making sure that we're meeting these timeline milestones that's been laid out. So certainly very disappointed with the delay, but I'm I guess more hopeful that the parties will move together quicker now that we identify these difficulties, and hopefully short of going to litigation, we could get the result. I mean, I have no interest really at the end of the day to litigate. I really want this built. So I really hope that all parties to work at post haste to make this happen. Thank you.
Thank you very much. Can we get a motion to approve the recommended action, which in this instance is simply the motion to receive the report?
Right, so move to receive the report.
All right, motion by Lee, second by Simidian. And let's just call the roll, Madam Clerk.
Roger, this is Jeff Draper. I just want to check that Dr. Smith's hand is up before you.
Forgive me,
your vote.
I missed it. I didn't realize he was going to share a little more. Go right ahead, Dr. Smith.
I just wanted to let the committee know that we're likely to be in closed session with the full board regarding this issue in the next few weeks, once we have more clear answers from Excel. So that will be another opportunity to ask more specific questions.
Thank you again. All right. Motion on the floor. Madam Clerk, please call the roll.
Vice Chairperson Lee
Aye.
and Chairperson Semidion.
Aye. Motion carries. Thank you very much. And that takes us to item number 6, which is our COVID-19 update and report. And I think I turn, as we usually do, to Dr. Cody. Dr. Cody?
Good afternoon, Supervisor Semidion and Supervisor Lee. This is Dr. Cody, and I will be giving you a brief report and then happy to answer any questions. Let me just share my screen. Hold on. I guess I'll just, while we're getting the slides up, I'm just going to share with you the epi curve, as I always do, shows that we in Santa Clara County, like the rest of the state and the country, are in a fourth wave. The fourth wave that you can see on our dashboard in my slide, I'm sorry, I'm having a little bit of trouble with it, but it basically shows that we're continuing to increase. And I would note that Kaiser Northern California continues to have challenges getting their data into the state system. And that affected the data since the end of July. So it's a little bit difficult to interpret just where we're going. It looks to me like our cases, there we go. Hopefully you can now see my screen. Our cases are still trending up. I would note that in other parts of the state and the region, some jurisdictions feel that maybe they're reaching a plateau or beginning to turn the corner. We're not seeing that here quite yet. Our hospitalizations are also continuing to trend up, and we've not seen a plateau just yet. This shows our case rates, and they're divided by the unvaccinated and the fully vaccinated. And you can pretty clearly see that that orange line, the case rates among unvaccinated, is significantly higher than the county overall, which is in gray. And as to the question as to what's driving the case rate among the unvaccinated, it's much more the eligible but unvaccinated rather than the not yet eligible to be vaccinated. In other words, the children under 12, and they're shown in the purple line, their case rate, so they're not yet eligibly vaccinated, is a bit above the fully vaccinated case rate, but not significantly so. So it's really the unvaccinated older children and adults that are driving that unvaccinated case rate. A little bit more about the description of who's vaccinated, who's completely vaccinated in our county is shown here. First, I just want to note that as of yesterday, we are up to almost 81% of eligible county residents fully vaccinated, with 86.5 partially vaccinated and on their way. And that's tremendous. And we really can't understate how protective that has been. I just want to point out a few things about this description of who is vaccinated. First, females have a slightly higher vaccination rate as compared to males. And race ethnicity, the vaccination rate is extraordinarily high among various Asian subgroups. And the vaccination rate among African Americans, whites, and Latinos are about the same. Mid to high 60s in each group, not significantly different. So we're not seeing some of the disparities that are being seen in other jurisdictions. Whoops. I lost my screen share. I apologize. The final slide, actually, I think that may have, that was the final slide. So Happy to entertain any questions that you may have regarding vaccinations or any other COVID topic.
Thank you. I think before we go to questions or comments from the committee members, I'd like to ask if there are members of the public who would like to speak to this item. And let me ask the clerk how many folks we have who've indicated a desire to speak on this item.
We have 4 members currently of the public that wish to speak.
All right. Let me do this. Let me, just so we can manage time fairly, ask if you are a member of the public who would like to speak to this item. And again, this is our item number 6, the report on vaccines and COVID-19. Please indicate so at this time, because we're going to assign time and then cut it off based on the rules of the board as contained in our published agenda. So let me check again with the clerk. How many folks do we have?
4.
All right, then we'll allow up to 2 minutes for these speakers, but we will cut it off at this time. Go right ahead.
Our first speaker is C. Connors. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Yes, hi, thank you. I am actually curious as to a couple questions on this. What point are we considered as a county fully vaccinated? It's been mentioned a couple times that we're 80% vaccinated, as well as a first shot, and another 80% has 1 shot. So what's the end goal here? That's my first question. And second one is, you guys have mentioned, or Dr. Cody has mentioned, that it's a pandemic of the unvaccinated. What is the disparity of testing between the vaccinated versus unvaccinated? The more unvaccinated versus vaccinated who are being tested, obviously we're going to have more test results or more positive cases. We also know from the CDC that if you're vaccinated, you're not immune from getting COVID and you're not immune from spreading it. Therefore, if we're going to really compare the unvaccinated to the vaccinated, doesn't it make sense that we are comparing apples to apples and actually testing vaccinated people as well as unvaccinated? So I'd like to know the disparity of how many of these vaccinated people are being tested and how many of those tests are coming up negative, as opposed to the percentages of how many unvaccinated people are being tested and those coming up negative. I feel like there's quite a large disparity in that if you are unvaccinated currently, your job is requiring you to test weekly, and therefore the percentage of people who are unvaccinated testing positive is going to be higher. But how many of those are also asymptomatic? According to the CDC, they're not testing the vaccinated unless they're hospitalized or unless they're having a severe case. So I'd like to know what percentage of tests among the vaccinated are coming up positive in comparison to the unvaccinated. And I think those are important questions as we consider next steps. Given what the San Jose City Council implemented yesterday, I think these questions need to be answered publicly for all of us. So I'd love my questions answered, and I'd love to see the data on it. Thank you very much. Have a good day.
Our next speaker is Z. Latko. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, I looked at the data screenshots provided with this meeting. The second screenshot, case rates by vaccination status, shows that the rate for children younger than 12, which are all unvaccinated due to being ineligible, is on par with vaccinated adults and the general public. But somehow when the child turns 12 but doesn't get vaccinated, the vaccine, the chance of catching COVID becomes 4 times higher. Magic? To me, this looks like data manipulation and misinterpretation. Thank you.
Our next speaker is frustrated. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, yeah, I'm just kind of echoing the first speaker. How are you getting your data about the unvaccinated driving the case rate? If you are requiring testing of only the unvaccinated and not requiring it of the vaccinated, aren't you going to detect more cases among the unvaccinated? And it's, plus we already know it's faulty testing, but I mean, if the vaccinated who can also catch and transmit the virus, why are they exempt from testing? Couldn't they possibly be asymptomatic spreaders as well and driving the outbreaks and the cases. I just think your data is a little misleading. And I honestly think that we have seen a lot of misleading data come out of this department, and it's very frustrating for a lot of us because it's inaccurate. And I really think that you need to reevaluate how you're putting out your information and answer these questions, because people ask these questions all the time and nothing changes. We don't get answers. I don't know what you're hiding, but that's not a good look, and we should be open and transparent about this if we are going to come out of this pandemic. Thank you.
Our next speaker is Tino. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Mr. Simidian, I was glad to hear you support full transparency with testing, death certificates, and reports of deaths and injuries from the shots on bears. I always hear those those reports don't prove causation. Technically, that's true, but only because they are initial reports that demand investigation, which isn't happening thoroughly. I haven't seen any reports from the FDA that proves every death and injury are not due to the shots. Pfizer, by the way, has the most shots on that system. I'm asking you to pause all testing and injections so we can review multiple data sets, bring in other highly qualified experts for a more well-rounded and consistent conversation, and then execute quickly based on a thorough review. Many statistics we get in the US about vaccines do not match up with trends in Israel, the UK, and elsewhere. More data is coming out about the vaccinated spreading the virus. The CDC hasn't been testing the vaccinated the same way as the unvaccinated as far back as May. That's documented. We don't have true transmission rates. Anthony Fauci is on record from August 3rd saying the testing has not been able to differentiate between different viruses and flus while he promoted a multi-billion-dollar antiviral program. He said it was important to completely overhaul our testing strategy in order to properly diagnose and treat people. That means we haven't been able to do that up until this point. Many doctors have been pounding the table for repurposed drugs that have antiviral properties. The safety records are very good. Now the shots are wearing off and people need boosters. That proves we didn't have mid or long-term safety data. People were not told the shots would lose effectiveness and they would definitively need boosters in 6 to 8 months. We didn't even have 8 months worth of legitimate short-term safety data. The potential for antibody-dependent enhancement isn't new. Even Fauci and his network have previously talked about it. Many believe this is happening now. Please pause testing and injections and reassess everything immediately.
We have one additional speaker. Matthew, I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Yeah, thank you guys for the chance to say something. I don't know if Mr. Lee is there, but I know you are, Mr. Simidian. So my comment is simply this. We're being given a case rate statistic that's based on a formula that has a numerator and a denominator. And how we play with that formula can sometimes be misleading. So I would encourage you guys to look into what the actual head count is, because I'm doing the math the best I can from my limited epidemiology training, and I'm getting actual case counts, meaning the actual number of people that have COVID. So if we look at this chart that was just put up, fully vaccinated residents, 9.4 case rate, unvaccinated residents, 54 case rate. That's a huge disparity. But if we do the math to figure out the actual number of people, I'm getting numbers that are in the mid hundreds, and they're not that mismatched. Maybe 130 to 179 is the data that I have. It's not a grotesque 5 times, 3 times mismatch. The data from last week's meeting, the mismatch was off by just a few people, meaning we had almost, in fact, if you counted the partially vaxxed in with the fully vaxxed, we had more people being diagnosed that had had at least 1 shot than people being diagnosed who had had no shot. So the data, we're not seeing the raw data, we're not seeing the whole picture. And that's what I'm trying to encourage you guys to do, is to dig a little deeper, look at the raw data, look at the actual case count, get the whole picture. The lady before raised a very important point. If there's disparity of testing, we're required to get tested more if we're unvaccinated. That can drive up the case count. That can create a great asymmetry when comparing the 2 groups. So hopefully you guys could be mindful of that, and thank you for the time.
And that concludes public comment.
Thank you very much, Madam Clerk. Let me go to Supervisor Lee and give you the first opportunity for questions and comments, Supervisor Lee, and then I'll follow up with anything that remains that I want to pursue with our staff. Go right ahead, Supervisor Lee.
Yes, thank you, Chair. Thank you, Dr. Cody, for the report. Based on the dashboard from the second slide, it looks like we may be developing a cyclic trend with the COVID cases. The 7-day rolling average of new cases is similar to where we were at this time last year. With the transmissibility of Delta variant being higher, do you think this cyclic trend will continue this winter with the sharp increases in the cases we saw from last winter? Or do you think our high vaccination rate will then help lead to a lower peak than last time?
Thank you for the question, Supervisor Lee. I can't predict what will happen this winter. However, I think there's a couple metrics that are important to look at. One is case rate, but more important is hospitalization and deaths. And what I didn't show is looking at the trends and how many people in our county are dying of COVID. And it's now very few, which is different than any other time during the pandemic. And I think that's largely because of the high vaccination rate among people who are older and at greater risk of dying of COVID. So that really is important. So even if we see an increase in cases, I don't think that we would see the same increase in severe illness and death as compared to what we saw last winter.
Okay, thank you. Now, one of the chart I think I've been hearing from different reports, I don't see it here, is segregating those who are hospitalized that are vaccinated versus those who are not vaccinated at all. Is that something that we could also add in from now on in the future to something that's possible? Basically compare those who's been recently hospitalized as vaccinated versus unvaccinated and those who has been dying, the death rates of how many are vaccinated versus unvaccinated, because based on the public readings that we heard from other news sources is that it seems like a large portion of those who are hospitalized are still unvaccinated, correct?
Yes, that's true. I'll check back with our data team and see what the data that we have from hospitals and whether we can look at it in that way, because I take your point. The majority of those who are hospitalized are not vaccinated, but I do agree it would be, of course, helpful to see those data. So we'll check back from the team and see what data are available.
Great. Now, right now, as we know, the kids 11 under are not approved for any vaccines yet. I mean, the exciting news this week, of course, is that Pfizer has now been fully approved, is no longer under the emergency use authorization. So now this is a fully FDA approved vaccine for the Pfizer vaccine. So now for those who are under 12 years old, what recommendation would you have for our kids besides wearing masks?
For children under 12, I think there's a couple key points. One is that to the extent that the older children and adults in that child's environment are vaccinated, the greater protection that child will have. So when educators and staff at school are vaccinated and family members and older children are vaccinated, that gives protection to the children. In addition, the universal masking that we have indoors and at schools will also protect the child. And some of the basic concepts that we know and we've used throughout the pandemic, which is that you layer prevention measures, because one prevention measure alone is imperfect, but if you layer them, you get better protection. That still holds. So the vaccination of the community plus universal masking plus ventilation, improving ventilation wherever possible, holding events and gatherings outdoors rather than indoors. That's all tremendously helpful. And people have choices. So you could choose to not travel to an area where rates are higher, or gather with fewer people, or do less mixing. Those all also reduce the probability of exposure and can be helpful to anyone who's not yet vaccinated, including kids.
Right, exactly. Thank you. And I mean, we do have a mandate to require indoor to be vaccinated in the public area. I've personally recommended people that even though you're outdoor, especially when you're near different people, it would still be very advisable to be masked up just to protect yourself and protect others as well. So that's what I've been telling folks. And certainly want to hear any other advice you have for people to also as well in outdoor. I mean, certainly the good news we have right now is that we have not lowered the number of people allowed in indoor activities. We have not had to close down the gyms or restaurants and any of that, due to the fact that our numbers are still much lower than where it used to be, even though there is some higher number of hospitalization. But certainly it does seem like that the indoor masking has, since the order has come out, certainly has slowed down, if not really stopped increases. So I think these are, I think, very balanced approach that we're doing right now. And I just want to thank you, Dr. Cody, for all your great work leading this effort all this past year. Thank you.
Thank you.
Supervisor Lee, does that cover your questions and comments?
Yes, that's all I have. Thank you, Chair.
Thank you. Then I'll take the opportunity to ask a few additional questions, follow up on some others. Dr. Cody, and if you want to turn to anyone else as we walk through these, I will certainly understand. We have talked before at the committee and board level about the distinction, the difference between folks who are identified in the death toll as folks who died because of COVID, died of COVID, and those who died with COVID, but not necessarily with COVID as the reason for the death. Has there been some recent clarification or guidance from CDC on how to parse these numbers? And if so, could you share that with us?
Yes, as you know, in the beginning of the pandemic, we counted a COVID death as someone who had died and had a positive COVID test. And then over the summer, and I can't remember exactly which month it was, May or June, in consultation with CDPH and surrounding counties, we revised the way that we count deaths and reapplied it to all of the deaths. So we are now counting people who died of COVID rather than died with COVID. In other words, COVID is included as a cause of death on the death certificate. And so that aligns with the state and surrounding counties. And that's the way our deaths are now displayed. So I hope that answers your question.
Yes, let me ask if you could put back up on the screen one of the pages that reflects the total number of COVID deaths here in the county. That will help me follow up a little bit. And if you need a minute, I will understand given the challenges of our technology.
Yeah, I don't think that I had a slide that showed the deaths from our dashboard. I just had a slide that showed the cases. So we'd have to pull up the dashboard to look at the deaths. Would you like me to try?
No,
to do that?
that's all right.
Okay.
Let me ask the question this way without benefit of a slide then, which is presumably that adjustment resulted in a change in the total number of deaths reported, and that would be reflected in a quote lower number. Is that correct?
That's correct. Yes.
Okay. And so my question is is the data that our county is now sharing, presenting on its dashboards and on our website, is that data now current and revised to reflect the change in methodology? Candidly, I think there's some folks who think that the death toll is inflated, and I just want to be clear that the number that is being displayed reflects the revised guidance as to the distinction between those who died of COVID and those who died, quote, with COVID.
That's correct. The dashboard, both the cumulative number of COVID deaths as well as the death curve, deaths by week since the beginning of the pandemic, has been revised. So we took the new case definition and applied it to every death since the beginning of the pandemic. And that resulted in a revised number. It was less than it had been before. I can't recall by how much, as well as a revised curve of the number of deaths per week.
Thank you. And looking at the bottom of this particular visual, and thank you whoever found it because it is helpful. The acronym LTCF stands for what again?
Long-term care facilities.
Thank you. So the general public number is the lighter shade of blue, and the darker shade of blue represents the long-term care facilities, yes?
That's correct. And the reason you may recall that those are broken out is early in the pandemic, and certainly during the winter surge, residents living in long-term care facilities, which would include skilled nursing facilities, were at risk of hospitalization and death. And then once the vaccine was rolled out, and it was rolled out, one of the first waves included residents of long-term care facilities, you can kind of see how that proportion changed quite significantly.
Thank you. And just to close out the questioning on this piece around the count and the methodology, did I understand correctly that our methodology now, in terms of coming up with an analysis or a computation of the number of COVID-19 deaths, is consistent with the approach used in other counties and by the state and by the federal government, or is the federal government total still using a different criteria?
I know that our definition is now aligned with other counties in the state. I can't speak to the definition that the federal government is using or that other states are using, since I'm not sure.
Got it. But our methodology is consistent with the CDC guidance, which comes obviously from the federal government, yes?
Well, I can tell you that our definition is consistent with the state. So we align with the state. Whether the state aligns with the feds, I could research that and get back to you. I don't know off the top of my head.
Sure. That doesn't need to, I'd appreciate that if you could give us an off-agenda report on that, which of course is a public document available online. And it doesn't need to be lengthy, just literally a couple sentences to indicate whether our methodology is in congruent with or consistent with the guidance from CDC. I would appreciate that, and if you could share that with the committee, that would be great. Okay?
Sure.
Thank you for that. And then, you know, it's been a while since we've had a chance to talk, and I would appreciate your thinking these days about the range of tests that are out there. You know, we had the PCR test. There were other tests that we talked about. We've gone through some different approaches. I, at one point, learned how to pronounce the word nasopharyngeal, if I'm remembering how to pronounce it correctly. But where are we in the world of testing these days? What's your assessment on sort of the, you know, best practices in testing? Is there a particular test type that we think is the gold standard, for lack of a less cliched phrase, in terms of reliability, accuracy, cost, turnaround time, ease of administration? it's been a year and a half since we first were obliged to, or a year and a quarter at least, since we were first obliged to talk about testing. What's the state of the situation?
Well, I think the number of different testing options has expanded, and there's a number of tests where you can get rapid results. You can now go into a pharmacy and buy a test to perform at home, for example, which wasn't the case when we were talking about this a year ago. Many of those tests that you can buy and do at home, they might not be quite as precise as the PCR test that's done in clinical laboratories. And so that's kind of considered the gold standard. So there's folks often that PCR test will picks up little just little pieces of virus. So for example, someone might have an infection and test positive and then clear their symptoms, not be infectious to others. But if you test them, keep testing them periodically, their PCR test will still be positive. It will still be picking up, little pieces of virus, but it doesn't indicate that they're infectious. It just indicates that it's quite a sensitive test.
When, as I understand it, and if Dr. Smith wants to chime in here, that's fine too, or if you want to respond, that's whatever works. We have a system now here at the county where we're assessing whether or not folks are, in terms of county employees, whether or not folks are vaccinated, in which case, if they can come to work, they come to work and they've got a mask on, and that those who are not vaccinated are asked to test, I believe it's once a week. Does that sound right and current?
Yeah, that's correct.
And what test do we give them? And what's the turnaround time on it?
They get a PCR test, and the turnaround time is pretty fast. It's usually, I think we promise 1 to 3 days, but I think it's generally the results are back next day.
Thank you. And, again, forgive me because the various approaches have changed over time, but that first PCR test, excuse me, which I describe as the nasopharyngeal test, was quite an experience. I'll let it go at that. It was a pretty deep probe. Do I understand that the current tests are less intrusive, for lack of a better term?
So when you say nasal, I think what you're referring to is the type of sample needed, not the actual test. So it used to be that for all the tests, whether you were running a PCR test or an antigen test, those are the quicker ones, you needed a sample from, way deep into your nasopharyngeal area. And so those were the ones where you felt like someone might be about to biopsy your brain.
Yeah, that's the one.
Right? Yeah. So now we have nasal swabs. And so the nasal swab sample, which is, just your nose, not way back beyond your nose, those samples are sufficient to run a PCR test or many of the antigen tests.
Great. And if I were to ask you thank you for helping to clarify my casual use of the terminology. And do we have a current understanding or estimate of the accuracy rate of the PCR tests, either as to false positives or false negatives?
We do. So there's a sensitivity, which is of all those folks who are actually infected, how many are picked up by the PCR. And there's the specificity, which is of the people that are not infected, how many would have a negative test. I don't have those exact numbers on hand, but I would say that PCR tests in general are exquisitely sensitive. So if it's there, it will pick it up.
And false positives?
So extremely rare. But as I was mentioning before, a positive test does not necessarily mean that you're infectious. And so the example would be somebody who is positive and then might continue to have a positive test for quite some time after they're no longer infectious.
Thank you. Dr. Cody, could I get those numbers on what I'm going to colloquially call false positives and false negatives and the reliability rates for PCR tests? Could we get those in the same off-agenda report, please?
Well, they vary by test. So every manufacturer that makes a PCR test is going to have a slightly different statistic. So so that's kind of in the material. So there's not just sort of a simple one single number for a PCR test. Depends on which one.
Sure. If you could give us, though, a range that is your best professional estimate of, is going to pick up 90 to 95% or 20 to 25%, that would give me some order of magnitude at least. Okay.
Okay. We'll see what we can pull together.
Thank you. And then last question on PCR tests for me is, and do these tests distinguish between and differentiate between identification of COVID-19 and some other kind of viral presence, flu as an example?
Right. So you can labs can buy different kinds of tests, and so you can buy a test where you just look for COVID-19, or you just look for influenza, or you just look for another virus, or you can buy what are called multiplex assays that will give you results on more than one virus. So for example, in our public health lab, we run a multiplex assay that looks for both COVID-19 as well as influenza A and influenza B.
When
so
we
you can get the multiple or the single, whatever your lab chooses.
When we're looking for multiple, when we get the results back, do we know the difference? Do we know, does the test result say, yep, it's one of these three, or does it say, yep, it's a positive test and this is the specific thing that we found? Do you understand my question?
Right. No. So the test would tell you, yep, you have COVID-19, or yep, you have influenza A, or yep, you have COVID-19 and influenza A.
Got it. Okay. Thank you for that. And then could you tell us a little bit about what's going on with the adverse event reporting systems, the VAERS acronym, sometimes referred to as VAERS?
Right. So VAERS is a federal reporting system. Providers must report to VAERS. So if you have a patient and they've had a immunization and then something happens and you think it might be related, as a provider, you're required to report into VAERS. So it's a federal system. It's not a local system or responsibility, or a state system or responsibility. It's a federal system. So those, and then the VAERS data are pretty messy because, they get all kinds of different reports. And then there's, and so the VAERS data, just the reports in, are a little bit, they're difficult to interpret. So there's other groups, and I can't tell you a whole lot about them, that look at those data very carefully and investigate to try to understand any worrisome signals that could indicate a problem with the vaccine. So for example, in more myocarditis than expected in recipients of COVID vaccine. I believe that was probably picked up through VAERS.
Got it. Thank you. And I noted the term messy, which I assume is a highly technical medical term of art. So I'll make a note of that. And last question for me today is, we continue to have people express concerns, as you know, Dr. Cody, about the safety of the vaccine and the data around safety and deaths attributed. What can you tell us today about the safety of vaccines and/or concerns that people might have?
I think with a vaccine, the safety thresholds are pretty high because you're giving a vaccine to prevent something, and so you certainly don't want to cause a problem in the process of preventing something. These vaccines were well tested, and now in the last 8 months, we have quite a bit of worldwide experience with them, and more data coming in, and these systems to look for adverse events. So I feel quite comfortable with the safety of the vaccines, given the experience that we've had. The other thing, just sort of to keep in mind, just as context, is you're trying to weigh, you're trying to weigh harms and benefits, and so it's what's your risk of something bad happening if you get vaccinated, and what's your risk of something bad happening if you don't get vaccinated. So since we're living in the middle of a global pandemic and bad things happen if you get COVID, I think it's sort of a no-brainer that you get vaccinated. And there's not that many contraindications or reasons why you shouldn't be vaccinated. They're pretty few. I mean, it's essentially if you got a shot and it turned out that you were allergic to one of the individual components in the vaccine, that would be a reason why you absolutely can't get vaccinated. But that's about it.
And does the recent approval that Supervisor Lee referenced with the Pfizer vaccine provide some additional increment of reassurance?
I think it does. I think that many of us felt quite comfortable with the vaccines even before the full FDA approval. And nevertheless, I think it's important and a very important step that we now have final and full FDA approval for the Pfizer vaccine.
And you may,
and they get, yeah.
Forgive me, I didn't mean to interrupt.
That's the FDA approval. I just wanted to just for the sake of precision, is for 16 and up.
Got it. And any sense of whether or not that approval will perhaps move some of the folks who have thus far been vaccine hesitant into greater receptivity to the vaccine?
I think it's a little early to tell, although what I hear from our county vaccination sites is we did not see a bump. We didn't see folks rushing in after the news of the full FDA approval. There may be, I know there's got to be some folks who were on the fence, and that helped reassure them and get them to a vaccine site. And maybe others who are vaccine hesitant have different concerns.
All right. Thank you very much. I have no further comments or questions. Supervisor Lee, if you have some follow-up, this would be the time. Otherwise, a motion to receive the report would be timely and appreciated.
Thank you. I don't think we ever run out of questions about these issues. But again, I mean, the rules are changing so quickly. We have so many different variants. I hope we don't run out of Greek alphabets when it comes to variants. That's all I hope for. And I don't have any further question. Thank you. I'll go ahead and move to receive the report, please.
All right. We have a motion by Lee. I will second. We'll ask the clerk to please call the roll and say thank you again to Dr. Cody and her team, as well as to members of the public who weighed in today.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye. That is a unanimous vote. We have received the report. Thank you again to all. That takes us to item number 7, which is to receive the report from the Santa Clara Valley Medical Center relating to sexual assault forensic exam services, so-called SAFE services, at all of our safe response sites. Let me turn first to county staff, and then if they're available, I would like to hear from folks at Stanford Hospital as well, because that has been a site of particular interest and attention. So Mr. Loren, shall I start with you, or Ms. Berlini, or Ms. Walker? What would you suggest as a starting point in a report to the committee?
Thank you, Chair Simitian and Supervisor Lee. Chair, I would suggest we start with Kim Walker. Kim.
All right, Ms. Walker.
Afternoon. Thank you, Chairperson Simitian and Vice Chair Lee. We are here today to provide the report back after the HHC meeting in June. You have the ledge file for this, but certainly after the June meeting, we immediately started working with Stanford particularly and looking at options that would include not only the needs for us to be able to do our exam at that response location, but also folding in all of the public comment and the issues and concerns that were raised through the comments. We've been working closely and we've successfully found a space with the great work that Stanford has done. And it looks like it is going to provide everything that we need. And again, folding in all of the issues and concerns related to the comments. So I'm happy to talk about that. And I'm happy to take any questions regarding the current plan and any issues that you want to bring up.
Let me just ask you to share a little bit more there. And thank you, Ms. Walker. I think when we talked about this at our prior meeting, we talked about things that might be done, that could be done, and that we hope would be done to improve the facility immediately, particularly with respect to the experience of survivors who are obliged to use these services, and then focus in the near to midterm on a new space, what some refer to as a dedicated space, as distinct from a designated space. So let me ask you to sort of go into a little more detail, kind of on first is sort of, were there things that you could share with us today in addition to what's in the report, because I know this has been an evolving effort, about immediate improvements, and then your sense of where we're headed in terms of this issue of dedicated rather than simply designated space. And then after we've heard from you, you know, and Supervisor Lee has a chance to ask questions and make comments, I'd like to ask the Stanford folks to weigh in as well. Go ahead.
Certainly, thank you. So we've kind of taken a three-stage approach to this. We want to see what we can do immediately, so that the next patient that walks in, we can fix any of the issues that might currently be present, which would include space immediately to triage the patient, making sure there's, you know, a private space available, which is available, but we changed the workflow a little bit. So the safe nurse is involved immediately, and we're part of the decision-making process for the patient so that they don't have to have an undue delay for law enforcement to arrive, anything that would cause a delay outside of Stanford's ability. So looking at the workflow and making sure that we can shore up any gaps or barriers there, and we've done that. We also have an interim plan that the space that is being looked at to create a dedicated location for us, we would be able to utilize in the short term. There are some changes that would have to happen in the long term that would make it completely functional and doing everything that we're looking at as meeting best practice for a response location. So in the interim, we would be able to have on-site a confidential interview space, confidential location to go immediately after triage, confidential exam room, and private bathroom with this space for showering, all kind of in this one location, away from the lobby, away from any potential access by, you know, perpetrators, confidential that nobody could overhear them, speaking to a provider, and then all contained for the examiner so that everything happens in one location.
Thank you. It's so, sounds to me like essentially you've taken my my two-part construct and turned it into a three-part construct, because there is an appreciable improvement possible in the middle ground. Did I capture that more or less correctly?
Correct.
Okay. That interim step, does that go a little or a long way towards reaching the what I'll call the ideal circumstance of the final product?
Yes, it goes very, probably about 75% of the way there. There will be some preparation needs that we have to accomplish in order to move into that space now. And then more long-term, waiting for regulatory approval, OSHPD approval, to make sure that, you know, doors that need to be built or doors that need to be closed and showers that need to be rearranged all can happen. But we have all of the components available now. So we're much further along than we were in June, and really the patient experience is quite a bit improved.
And you know, I hesitate to ask but I think you were on the meeting here, or in the meeting when we heard earlier about delays associated with OSHPD for the psychiatric facility. Should we just understand and expect that sort of final approval or final product, the sort of the ideal that we're striving for, is likely to be delayed by that state approval process, the timeline associated with that?
My assumption is that it would maybe possibly follow that, but I would ask that of Stanford. They're the ones that are in contact with OSHPD for that purpose, so they would know better than I.
I ask in part, Ms. Walker, because I was encouraged to hear you say that the interim step went a long way. That's my word. I think you said 75%, but went a long way towards reaching that sort of best practices approach that we want to try and incorporate. So it sounds like pursuing that interim approach as quickly as possible is worth every effort if it's going to produce that much incremental improvement. So pleased to hear that. Let me ask who's with us from Stanford University, or the hospital, I guess I should say, and see what they can and would like to share about the progress we've been able to make and are hoping to make in the coming months.
Yes, good afternoon. This is Allison Kerr. Can you hear me?
You're coming through loud and clear. Thank you, Ms. Kerr.
Great. So thank you very much, Supervisor Samidi. And if it's okay with you, I just sort of like to read some statements that I have prepared that I think will supplement Kim's presentation, if that works for you.
Please do.
So over the last few months, we've listened to the constructive feedback from the county at large regarding the County Safe program at our location. And after several weeks of discussions and planning, we're prepared to set forth, as Kim outlined, several modifications to our SAFE program that will continue to ensure the safest, most compassionate, supportive care for survivors of sexual assault by providing a physical setting that is equipped to meet their needs. In the short term, or the interim plan that Kim referred to, we are creating interim suites that will include a separate private waiting room, separate private exam room, separate private bathroom exclusively for the SAFE program. While we are aware of the training needs that county SART nurses need to go through and appropriate workflows, we at Stanford Healthcare are ready to activate this interim space by September the 1st, which includes getting a CDPH program flex from CDPH. We're also modifying and streamlining our intake process, as Kim talked about, at our SAFE locations to make it more safe and supportive for survivors. All of these changes are done in support of Kim and the SART program. And then in the long term, the longer term construction project, we've begun that process of designing new multi-room space. It's a full suite that will be dedicated to the county's SAFE program. This involves hiring architects, construction firms, applying for county and state permits, remodeling of the existing space. And in fact, we relocated all of our hospital interpreters and our international medicine program. We moved them out of their space. And those interpreters, you should know, support all of the hospital, including ED patients, but we moved them all out such that we could use this space as it is contiguous with the emergency room, appreciating that we couldn't do that within our emergency room footprint, but we needed it to be contiguous. So we moved the interpreters and our international medicine program. So from design to completion, we plan to activate this permanent space in September 2022. So to your earlier question, Supervisor Simitian, about OSHPD, we have already sort of touched base with them. We already have construction plans underway. We've worked with Kim and a number of her team members to walk the plan. Andrea's walked the space. And we continue to get sign-off each stage of the way. And we believe that we will meet that final construction OSHPD deadline of being complete by September 2022, which is remarkably fast in our world of, obviously, of hospital construction. This renovation will produce a dedicated safe suite that will be available 24/7. The suite will include the private bathroom with a shower, a private consult room and private exam room, a private and secure storage area for safe carts, a private dedicated waiting room within the safe suite. This suite will be solely for survivors. As the only level 1 trauma center, as you know, between San Francisco and San Jose, we receive critical care patients and continue to support both our sexual assault survivors and those that have acute emergent medical needs. With over 100,000 ED visits, it's our top priority ensuring that we keep our ED capacity flowing, especially now with our growing population and our ever-increasing COVID demands, both within our surge as well as right now, which quite honestly, we have a surge of patients. We're committed to including a private, dedicated, safe response location in our emergency department for survivors in the surrounding North Santa Clara County community. With the fall term approaching, our team is also working in partnership with the County Safe program with Kim and her team and Andrea and the leaders at Stanford University to increase awareness of the services available in our emergency room for survivors of sexual assault. Our team has met with the executive director of the on-campus Student Health Center, which is the Vaden Health Center, with leadership in the Office of Institutional Equity, Access, and Community, and with the University Title IX Coordinator. Meetings are currently scheduled with the Office of Vice Provost for Student Affairs, as well as the University Confidential Support Team, who provides support and counseling for students impacted by sexual assault and relationship violence. Also included in our outreach and education efforts is to connect with local community partners, including Ravenswood Community Clinic and Planned Parenthood in Mountain View. So as these developments proceed, Stanford Healthcare, in partnership with Santa Clara County, is dedicated to ensuring the very best compassionate care and continuous improvement for our shared safe program response site. And I think I would just echo Kim in closure that she said that the space that she's walked, the interim space we're creating and the final space that we'll have will be best practice. And she'd love to have that in all of those locations. So thank you for your time, and I'm happy to answer any questions.
Thank you. Before I turn to Supervisor Otto Lee, I just want to confirm with you and with Ms. Walker. I heard an estimated completion date for what I'll call the ideal solution here, September of 22, given the need to wait for various state approvals. And I've had my own experience and frustration with how long those can go. But it does, as I indicated earlier, I think, make that interim solution all the more important and pressing, particularly if it gives us 3/4 of the benefit that we hope to ultimately derive. Did I hear a date from you on when that solution could be identified? I thought I heard September 1st of this year. Did I get that right?
Yes, sir. So for Stanford Healthcare, that space will be available September 1st with the CDPH flex approval. Kim needs to, I know, and Kim can obviously speak for herself, but I know she has to do some educations on workflows for her team. And so we'll continue to partner with Kim in ensuring that we have a shared go live date. But from a space perspective, we will be ready. And we'll just work with Kim. We'd like very much to time it, obviously, for the start of the Stanford students, which is September 11th.
Got it. And then let me turn to Ms. Walker again. Does that work for you, and is that consistent with your understanding, Ms. Walker?
The September 1st date, we would not be able to start, but I know that the space will be available and with all of the elements that we would need in the space, but it now will require us to go in and then tabletop all of the different components of the exam to make sure that there's no loss of quality for what we have to do in the exam, and then make sure that all of the examiners know the workflow. So we will do that as quickly as possible.
And forgive me, I know that it's a little hard because it's a hypothetical, but is that after that September 1st date, if the facility itself is available, is that a matter of days, weeks? Just trying to get an order of magnitude here.
I would need to be able to see the space with all of the components in it. I have not seen that yet, so I would love to be able to answer that in September. I will have that definitely an answer for that, but I would assume it's weeks.
All right, thank you for that. As you may recall, our next HHC meeting, the Health and Hospital Committee meeting, is scheduled for Wednesday, September 22nd. And Ms. Walker, you may recall that when we took this matter up back in June, I asked for essentially status reports in every other month fashion, but that we would have this status report on progress. And thank you, it's an encouraging one. You know, more or less in a sort of a update fashion, but that by September we were hoping to have what I'd call sort of tangible deliverables. Sounds like that's still a good plan given the September 1st date and the ability then of your team to assess sort of how much time you need thereafter. So can we ask you to come back to us, Ms. Walker and colleagues and folks at Stanford on September the 22nd with what I'll call, you know, sort of a more fully fleshed out set of deliverables and any update on the timetable that you might have. Yes?
Yes.
Okay, thank you. And Ms. Clara, would like to ask you back again at that time so that we can confirm that the space has in fact been available, and if that works for you. And Ms. Walker and Ms. Clara, I'm going to ask you both because I know that you know, words matter in this case. To your way of understanding as professionals, the space we're talking about will be, quote, dedicated space as opposed to simply designated space. Ms. Walker, yes?
Yes.
Ms. Kerr?
Yes, we removed the folks that are working in that space, so it will be dedicated for this program completely.
Thank you very much. All right, let me turn to my colleague, Supervisor Lee, see if he has questions or comments. And then, Madam Clerk, we're going to want to go to members of the public, and so we would ask them to get themselves in the queue if possible, so we know how many we're going to be accommodating today and can select a time accordingly. Go right ahead, Supervisor.
Thank you, Chair Simitian. First of all, I just want to say thanks for the report this time around. Compared to what we heard last time, which basically was saying that what we had was good enough. Clearly it wasn't, and I'm very, very glad to see that we've made these huge progress of where we're at this point. And this construction schedule of 1 year is certainly very, very fast, and I'm glad to hear that this is happening and that there's an interim plan as well to start September, which is so needed before the full facility could be established right by the ER area. When I read the report, it also indicates, so a couple of questions. One indicates that at the point of initial contact, like through the SAFE program, that's where we have the physical and psychological services being offered. My question is about the follow-up. For the survivors and the victims, what additional wraparound services are being provided and connecting to these survivors to long-term services beyond the initial interactions? And if you could elaborate that for me, I appreciate it.
Certainly. So if the survivor comes in and they accept services with the Rape Crisis Center, the advocate that's confidential, they follow them not only through the exam portion of what we do, but also any follow-up exams that we might do, and they provide support throughout all of the care needs after up to and including court and trial accompaniment. So they are the ones that provide that service. For us in the medical arena with our exams, we'll do an initial exam. If there is a need or injury that has been found that we need to do a follow-up, we offer that as well. And then of course we refer back if there are emergency services needed, provide information so that their primary care physician knows what we've provided to them medication-wise or care-wise so that it doesn't get duplicated unnecessarily. But regarding additional care, it's normal medical care.
Right, and we talk about both, not just physical care, but also any psychological services as well, correct? And behavioral health.
Yes, and so obviously if we're co-located with an emergency department, we have access to medical social workers, we have access to behavioral health care, we have access to all of those services, and Stanford is no different.
Right, and you mentioned the safe nurse, and this is somebody who is available on call or 24/7 to assist these cases when these issues happens, correct?
Yes.
Okay, now the professionals that's working with the survivors, I would assume, and you can confirm with me, that they all culturally trained and informed, and also work with many victims that might not be English speaking, correct?
Correct. We also have translation services in addition to ongoing competency care and education. We stay current just like any other provider in the hospital system.
Okay, and regarding the SAFE program, do we have actual written information or resources that are available in different languages?
Yes, we always provide our information within the languages that are required, but then we make those languages, that information available in additional languages as needed.
Okay, good. With the, as you know, we're having some construction as our own VMC emergency department. The report notes that the examiner's process or order of operation may be impacted. How would this affect or maybe extend the duration of time that the survivor might have to wait for the services at the hospital?
When talking about Stanford, then the construction that would be going on there to update the space that we're looking at, we would have a backup plan that would still contain all of the elements that are needed for patient experience and for the exam. And then we would also make sure that we mitigate any of those issues throughout the process. Stanford is very good about communicating with us. So if there would be a change, we would be able to accommodate that immediately. And the similar situation for VMC.
Okay, and then my last question is regarding the time of the results, because there's been a concern that any long turnaround time with the survivor receiving results from SAFE might adverse effect on the healing process. Could you please provide me some insight as to the average turnaround time for the survivor to receive the results of the examination through the SAFE program?
So because we do a medical evidentiary exam, the two components of what we do, the medical care is always priority. So the things that we do for sexually transmitted infection identification lab work, we have stat and routine lab work. We will get those back to the patient. Anything else medically, we would get to the patient either that at that time or like the next day. With regards to the evidence collection and the kit that we collect, that goes to law enforcement, gets submitted to the crime lab. And I can tell you that in Santa Clara County, that turnaround time is less than 30 days to get those results back. However, the standard is 120 days. So we are well ahead of that in Santa Clara County.
Right, that's for the reason of those rape kits that was backlogged, and we put resources, right, last year to change, and that's the result of that, correct?
I think it's, yes, in large part to that, yes.
Okay, good. And that's all the questions I have. Thank you very much.
Thank you. I have probably a couple of just process items I want to pursue, but I also want to hold off on any further questions until we hear from members of the public, because that may spark some additional follow-up from either of the two supervisors on the committee. So let me go to the clerk and ask, do we have speakers on this item?
We currently have 4.
All right, let's go ahead and ask those speakers to line up in the queue, virtual or otherwise here, and we can accommodate up to 2 minutes given the relatively modest number of speakers. Thank you.
Our first speaker is Elizabeth Kim. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, everyone. I'm Betsy. I'm a senior at Stanford, and I'm speaking out of concern as an incoming resident assistant at one of the undergraduate dorms. It certainly wouldn't shock me if one of my residents approached me because they needed to obtain a SAFE exam, considering the prevalence of sexual assault on campus and particularly how often it happens in dorms. It certainly is not a hypothetical situation. And in the event that it happens, I really would want to be able to direct my residents to a place where their identity, their confidentiality can be assured. So providing a dedicated space for a private waiting room for students seeking a SAFE exam is obviously a critical, non-negotiable component of that. And to add to a sense of urgency on the issue, I think it's important to note that the first few weeks of the school year on college campuses is commonly known as the red zone, when the majority of sexual assault happens in a very concentrated time frame. I myself will be moving to campus this Sunday to start RA training, and the majority of students will be moving in a couple weeks after that, in early to mid-September. So certainly I would be very disappointed to see any delays in the deadline of September 1st of this year that Vice President Kerr mentioned. Thank you.
Our next speaker is Jody Vogel. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Hello, everyone. I am Jody Vogel, an emergency medicine physician and vice chair of academic affairs at Stanford Healthcare. In my career, I have cared for countless survivors of sexual assault and am fully committed to ensuring that survivors who come to Stanford Healthcare receive the very highest standard of care, compassion, and privacy. The county's SAFE program response location at Stanford Healthcare is a safe, compassionate, fully equipped, and staffed setting developed in collaboration with and approved by Santa Clara County. While our program meets all the stringent requirements and protocols for maintaining evidence as a necessary part of the evidence collection process, we are determined to make the experience for survivors as strong as it possibly can be. Nothing less will do. We have heard the concerns of advocates and have been in active, productive discussions with the county to jointly address those concerns. As you have heard today, these plans include short and long-term modifications and dedicated suite for survivors of sexual assault. Stanford Healthcare's emergency medicine physicians and staff are devoted to providing the highest standard of compassionate care, which requires that we always remain open and humble to feedback and committed to continuous improvement. We care for survivors of every age, gender, and level of acuity, and deeply understand and care about the unique experiences of each patient. We recognize the importance of a program and process tailored specifically for survivors. As planned improvements take shape in the upcoming weeks and months, we will do everything to continue to ensure that survivors of sexual assault experience the best possible, safest, and supportive environment for SAFE exams at Stanford Healthcare. Thank you.
The next speaker is Emma Surkoff. I am unmuting you. Please accept the unmute and you will have 2 minutes to speak. The timer will start when you begin speaking.
Hi, everyone. I'm Emma. I'm a graduate student at Stanford University. And while I appreciate the pre-written PR statement we just heard, I want to remind all of us that we are here because in 2018, Stanford's president wrote a letter to Supervisor Simidian promising that there will be a dedicated space for start exams, and we were told we should wait because a new ER is being constructed, and then it was constructed, and now it's pretty and beautiful, but there is still somehow no space there for the start exams. So while it sounds like everything is good and there is no reason to be frustrated, I want to convey the message that we are frustrated because we have heard this beautiful statement and PR releases multiple times, and yet the situation on the ground is still not where it should be. Until a couple of months ago, survivors would go to get a SART exam. There will be a displaced cart, an unplugged iPad, and a public room that is shared with others to do the triage. So let's remember that. But in addition to that, I wanted to specifically ask Ms. Clara if she can clarify whether the triage for people who are coming in to do the START exam, would that be happening inside the ER, or would that be happening in the interim space right away? Because I think that is one of the crucial parts. I know that ER rooms can be really hectic, and it would be great if the triage doesn't have to happen with a nurse before it gets diverted into the START exam space. So I was hoping to specifically hear that.
Our next speaker is Michelle Dauber. I am unmuting you. Please accept the unmute. You will have 2 minutes to speak. The timer will start when you begin speaking.
I'm Michelle Dauber. I'm a professor at Stanford. It's good to see that Stanford is finally moving toward remodeling and creating a suite for survivors, although I do not actually see a solid commitment in the report itself. That process, if it occurs, will require state approvals and take a long time. At this point, it is essential that Stanford provide, as an interim measure, a dedicated private waiting room until the remodel is completed. Students, workers, and others are being raped right now. Rapists are not waiting for the remodel to be completed, and neither should Stanford. In 2 weeks, 2,000 freshman students from at least 2 different classes will descend on Stanford campus, most for the first time. If the past is any guide to the present, there will be a historic amount of rape on Stanford campus. Stanford Hospital sits on 1 million tax-free square feet of property in this county. Stanford can find 1 dedicated waiting room for rape victims today. This should be available starting right now today through the completion of the remodel. Vice President Kerr, I want to know if you will commit right now to make a dedicated waiting room available starting today, and if not, why not? I also, Vice President Kerr, would like you to speak to Emma's question about whether triage can happen in a private space starting immediately. I understand that some things cannot start immediately, but I think that those 2 things can. It is clear that this model is essential to meet the minimum standards articulated in today's staff report to protect survivor privacy and physical and emotional safety and security, following the very disturbing revelation that a student survivor was identified by another student in Stanford's public waiting room, among many other issues. So like Emma, I would like to hear these direct responses from Vice President Kerr. Thank you.
That concludes our public comment.
Thank you. And thank you to those who took the time to be with us today. Ms. Walker, let me just ask that when you come back to the committee on the 22nd, we have further refinement of the interim plan and the final plan sort of very explicitly available, including not only physical space, but the flow as you describe it, so that we can talk about it at that time. And I should also mention, Ms. Walker, I think you know that I'm scheduled for a site visit there at the hospital on, I believe it's not this week, but next or the week thereafter. I will want to ask that you and anyone else who can be helpful think of that as an opportunity to help convey the survivor experience as much as possible, every bit as much, if not more, frankly, than the sort of the hard medicine or healthcare side of the conversation. I think that's what I'm hoping to understand better by virtue of looking at what's in place today, what the interim plan looks like, and what the end plan looks like. So I just wanted to use this opportunity to ask for that in advance. We will, as I'm sure some of you will recall, also have the benefit of the Harvey Rose management audit findings, I think in December. And the notion there was to sort of have an outside third party, if you will, provide some oversight and comment after the process had run its course to make sure we don't miss anything on the way through this effort. And Ms. Walker, are you in a position to respond to either the concerns that was addressed about both the confidentiality during triage and or availability of a private and dedicated space? The impression I had from your presentation and that of Ms. Carr is that the interim solution, while it ultimately calls for some physical improvements, does in fact provide that dedicated space or not. Could you help me with that understanding, please?
Currently, there are 2 confidential rooms that one is where the patient usually is taken, but there is a second one that potentially could be made a dedicated space, but either of those are available to the patient now as a confidential private location immediately after the triage. So those are intact. As far as the triage is concerned, in the emergency department, there are 3 triage rooms that are private, that the patient can be immediately taken into through the emergency department lobby. They go straight in there. Doors are shut, it's private and confidential. They can have their triage and their screening done medically, and then they're able to go to that confidential location. So yes.
Excuse the interruption, does the patient need to know to ask for a private triage space, however?
In the screening, if they have disclosed sexual assault and have been identified as a survivor, they will be taken there as part of the workflow established by Stanford.
All right. Why don't I ask when you come back in September and when I visit the site, I think now I've clarified it's on September the 7th, if I could ask that you provide some additional clarity and detail about that. I think the concern, as I have heard it previously and again today, is sort of to what extent are folks obliged to relive the experience in a quasi-public setting, and I understand and am empathetic with that concern, quite frankly. Ms. Carr, if you have additional comments now, fine. If you'd like to wait until the September meeting, also fine. But I do want to ask that we follow up on that, and that when I tour, that I get some time to sort of walk through that part of the experience when we meet. Ms. Carr, anything else you want to add at this particular point?
Sure. I know Professor Dauber asked if I could commit to a private waiting room, and on behalf of Stanford Healthcare, I can commit to a private waiting room effective now, and the interim space will be available, which is private waiting room September 1st.
Got it.
We've done that all with Kim.
All right. Supervisor Lee, I see your hand is up again, sir. Let me go to you. And then if you'd like, at the conclusion of your questions and comments, to offer a motion to receive the report and direct staff to return with what I'll call deliverables at the September meeting, that would be a motion that was gratefully received.
Yes, thank you, Chair. My hand was up because we did receive some of the comments, Professor Dauber and others who spoke regarding the need of the privacy, and I think you have addressed those with Provost Kerr. So thank you for explaining that, and your commitment for the private waiting room certainly extremely appreciated by September 1st. My one other area that I forgot to ask earlier is regarding the victims that we talked about. We've been talking a lot regarding mostly cisgender female. There are, of course, victims of sexual assault who are male, or those who are non-conforming gender in terms of expansive individuals, such as those who are transgender, non-binary. I just want to make sure that those individuals do receive similarly competent services under these Safe Nurse program.
Yes, 15% of our patients are in fact, they identify as male. And then we also have treated and cared and responded to many survivors who identify without being binary. So we see everybody at all stages, and we meet them where they are, treat them with what they need when we meet them there. So yes, we have all of that capability.
Good. Okay. Thank you very much. And I'm ready to make a motion to receive the report. Thank you.
All right. We have a motion by Lee to receive the report with direction as indicated. Thank you again to all who participated and all who've helped get us to a better place in whatever role you may have done that work. I will second, and we'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
Chairperson Simitian.
Aye.
Thank you.
And thank you. That is a 2-0 vote. So the report has been received with unanimous agreement from the committee and direction, as I say, to come back on items as directed. And I will see some of you on the 7th for the tour. Thank you again. All right, that takes us to item number 8, which is recommendations relating to the Harvey M. Rose review of the fiscal year 2022 budget. Who would like to present here?
Supervisor, this is Cheryl Solov, the board's management auditor, and I am here to present. As you may recall, the board referred these items to this committee and also to the Finance and Government Operations Committee, which that committee previously met and had some input on these items. And I prepared a memo, which is, and the pertinent portions of which are on your packet, page 70, and extending to the following page or two, just to sort of update the numbers with the additional 3 months that we have actual data. At the time that we did our analysis, it was, obviously based on April numbers. And so we did update this for to include the final 2 months of the last fiscal year and the first year's, the first months of the current fiscal year. And none of our recommendations, there's no basis to adjust or change any of the recommendations that we originally made pertaining to these items based on any new information. Excuse me. I will say that we are awaiting new information or detailed information from the administration, which I expect we will see sometime Monday or perhaps Tuesday, pertaining to the behavioral health contract services. And so at that point, we will take a look at that information and perhaps provide an update with that in mind. So I just wanted to give you a brief summary of the kind of where we are right now. And I'm happy to answer any other questions that you might have.
Thank you very much. Supervisor Lee, if it's agreeable to you, let me first check with the clerk, see if we have any speakers on this item.
There are currently no speakers.
All right. In the absence of any public comment on this item, then we'll return the matter back to the committee. And let me just ask, Ms. Solov, there are two different ways to look at it. In my view, one way to look at it is sort of as just a budgeting practice and making sure that the numbers are right and in the right place, and that if the dollars are going to be, available somewhere else, that they be properly budgeted. The other way to look at it, though, and perhaps a matter of greater concern, and I want to go to Dr. Smith in a minute on this, as I read your report, to some extent read between the lines, I think the concern that exists is that, I understand that budgeted amounts are not by definition expenditures, but the goal is to allocate money to the budget for the kinds of services and the amount of service that we want to see as a board. And you're highlighting for us that that is not always happening. Is that the message we should be, is that the takeaway here? I don't want to put words in your mouth, but I want to make sure I get your point.
I guess it's more, that would be one way to put it. Alternatively, these are monies that we think will not be expended in the manner in which they are budgeted, which means it would just fall to fund balance at the end of the year, which is, acceptable. But we try to identify these items as for the benefit of the board, so that if there are things that are priorities, the board could adopt these recommendations without damaging, other existing services.
Thank you. I think these are two different, but albeit related issues. One is the availability of funds to be budgeted for other purposes, which you're highlighting, and the, hey, how come we're not spending this money for the services we thought we were buying, which is a second, somewhat different concern that I'm highlighting. Dr. Smith, do you have a reaction to this back and forth that I have prompted?
Well, Supervisor, we in administration see it slightly differently, which is where we end up with a difference of opinion. The way that the Management Audit Division is looking at the budget, they're looking at what is in fund balance on a previous year and guessing how much will actually be spent of money that's allocated for particular services already, and trying to suggest that allocations that have been made should be reversed in order to increase the fund balance for the subsequent year. It's a cash flow perspective. It's not a budget perspective, and that's why we get into trouble. For example, with the behavioral health services contracts, the 25 million that's referred to basically talks or relates to unspent funds that were already allocated by the board at contracts. And essentially the argument to spend that someplace else means that you would defund those contracts partially and allocate the funding someplace else. I think that does not recognize the fact, for instance, in that particular area, that there was a reason why the maximum financial obligation was not completely used up. The reason had to do with COVID and hiring and planning and a lot of other issues that the contractors have. So by allocating that funding someplace else, you do cause harm to behavioral health services. And the same is true with the project, capital project allocations. And the same basically is true for the vacant position funding. So it's a matter of whether the board wants to live up to its previously made commitments or allocations versus whether they want to start over every year and wipe the slate clean.
Well, I see it slightly differently, which is I think it's a matter of whether or not the numbers are real. And it's not a question of living up to our commitments. It's a question of whether or not, having made the commitment, our organization then lived up to the budget expectations that our board approved. Because I take your point, and I think it's a point well made, that, for example, on the behavioral health item, I think it's 23 million and change that the management audit team thinks might be reduced or reallocated. And you're saying, well, now there's a reason why that didn't get spent last year, and that the reasons that apply last year should not cause a diminution of funds this year. I think that was the argument that you made. But my question is, do we really believe that those funds will be spent and spent according to the budgeted purposes, in furtherance of the budgeted purposes this year? Or are we going to get to the end of this year and discover that yet again they are underspent? Dr. Smith?
Well, it's a best guess scenario. We're thinking that they will be spent. The contractors believe they will be spent. The behavioral health department thinks they will be spent. And more importantly, it's pretty clear that if we don't allocate the funding, the providers cannot plan for the expenditure. Therefore, they won't be able to do hiring, and we will go in a circular motion down the drain. So, you know, it's a best guess scenario, which is planning for the budget.
Yeah, Ms. Soloff, I think what I would encourage us to do as just one member of a 5-member body, obviously, is, quote, let it go this year. And accept the notion that there may have been special circumstances as one plausible reason for the under expenditure. But at the end of this fiscal year, ask ourselves if we're still underspent at something like the same level. And if so, say, you know what, it doesn't look to have been circumstantial. It looks to have been a continuing pattern, and then make the change then. How does that strike you, Ms. Soloff?
That sounds reasonable.
Well, obviously, I like that answer. Let me see what Supervisor Otto Lee has to say.
Thank you, Chair Simitian. Let me dial back a little bit, but I think we're talking about the same thing about item number 8, right, with the $25 million. So during the FGOC meeting last week, we actually had a very robust discussion about the historic underspending at the Behavioral Health Services Department, right? And when Cheryl noted that it wasn't clear to her if the excess unspent funds are allocated to current available contractors, at that time, Supervisor Chavez made the request to Dr. Smith to provide access to the VHSD contracts to the Harvey Rose, and I thought that made a lot of sense. Now, in my mind, part of the challenge is doing whatever it is that we can on the county's end to help address the historical underspending stemming from was hiring, and I'm wondering how much of that has to do with the perceived rigidity of existing contracts and those terms in the RFP to our nonprofit partners and the CBOs. So I would like to ask if the administration that they might be able to provide some type of report back to us in the September meeting, HUC meeting, to address the concern. And the chief concern was raised by the Behavior Health Contractors Association that was stated during last week's FGOC meeting. And the written recommendations that they submitted to Dr. Smith and Jerry back in July. My staff certainly have the digital copies of these documentations if they're not clear, and we'd be happy to share it with you, what we're referring to. But basically, I think there's been a lot of concerns from the contractors saying that, well, we really would like to spend, but due to these rigidity of the rules, we couldn't do it last year, and hoping that maybe this is one way to help resolve that problem, since as we all know, the need for mental health and behavioral health this year, especially after the shelter in place and COVID, has been astronomical. And those numbers are not only double, to some providers almost triple or higher. So I certainly do think that the funds is needed to be spent. I don't really want to return the funds, that is budgeted. I just want to make sure that those 25 million that was identified actually do get spent to the ones who need it. Does that make sense?
Yes, we'll include those discussions in the report back.
Okay, thank you, Dr. Smith. And that's all I have on this item.
Thank you. Then I think what I'd like to do is ask that we have a motion to receive the report pursuant to the recommended action in item 8 with the direction that you just provided, Supervisor Lee, and direction to our management audit team that if the amount remains unchanged, that we get a report back prior to next year's budget indicating the fact that the trend has continued, notwithstanding the difference in COVID circumstances. Okay.
Great, and happy to make the motion. So
and I'll second, and we'll ask the clerk to call the roll.
Vice Chairperson Lee.
Do we have public comments, Chair Siminian? I'm sorry.
I believe I asked, and there were none on this item.
Okay,
that's correct. Although we do now have a hand. Oh, it just went down again.
All right, let's go ahead and take the roll call vote, please, and then we'll move on to the next item.
Vice Chairperson Lee.
Aye.
And Chairperson Simitian.
Aye.
Thank you.
Passes unanimously. All right, items 9, 10, and 11 were placed on consent by our earlier action. And that takes us to item number 12. Item number 12, of course, is our, I'll call it our omnibus item here that includes a range of recommendations and reports in connection with our County of Santa Clara health system. Before I march us through those A through H, let me ask the clerk, are there individuals who'd like to speak on item number 12? Because that is the item before us now.
There are no speakers.
All right. Then in the absence of any speakers, let me turn to our director, Renee Santiago, and let you walk us through these items, Mr. Santiago.
Yes, and good afternoon, Mr. Chairman Simitian and Supervisor Lee. In my director's report and the written reports, I had a little bit of a history for background purposes for the committee in terms of Medi-Cal managed care, and obviously the control from payers to control cost as well as improve quality. I felt it was necessary to give you a little bit of backdrop as we encounter the upcoming negotiations with the federal government related to the state's proposal on CalAIM, which is fundamentally about reforming the Medi-Cal managed care system in California. So I had that as kind of a written background. The notable things in my report is some of the changes that the governor and the legislature have approved. Included on those items, if you recall, is the lowering of the eligibility for Medi-Cal for all residents to 50 years and above, which is good news. We are working not only with our teams, but also with the community health partners to identify those populations, since we had a primary care access program, PCAP, that served that population to make sure that people are informed. And then, of course, when it's effective in May 22, that immediately sees the opportunity to get coverage, Medi-Cal, and then, of course, get regular ongoing treatment. The other piece that's important is the significant investment that the state of California is making in behavioral health. We give you a summary of the major initiatives and programs. These are opportunities for us aligned with the board priorities to address the social, emotional, and mental health and substance abuse needs of our residents and our community. So we're looking forward to those opportunities to make sure that not only do we bring the resources, but as mentioned before, that we also improve our services and expand our capacities to serve more people. And then, of course, We have written reports and updates from each of the departments for your background. It's up to you whether you want to hear directly from each of the department heads or whether you just want us to go into questions and answers. We're perfectly fine either way. And then at the tail end, we do have an update from the federal perspective from Bert Margolin, who gives this as part of his monthly report. That will conclude my report, and happy to answer any questions.
Thank you. Let's see, Supervisor Lee, I'm going to march us through all of these as briskly but thoroughly as I can. Can I ask you to just lean in and interrupt if at some point you have a comment or question, all right? So thank you to Mr. Santiago. That takes us to 12B, which is public health. Let me just ask, is there anything else from public health in addition to the COVID report that we've already received?
No additional report from public health. Thanks so much.
All right. And that takes us to 12C, which is the report from the Chief Executive Officer at the Santa Clara Valley Medical Center. Mr. Lorenz, I think that's you.
Thank you, Chair Simitian. I do not have anything further to report outside the written report, but I'm happy to answer any questions that you may have.
All right, I'm keeping my eye on Supervisor Lee, who has unmuted himself. A question, or are you good to go, Supervisor?
Just a quick question for Paul.
Please.
Paul, it was great to see him and also his team coming out this Sunday for the race for the Stars and Stripes. Seeing that he's leading a great group of our VMC leaders, and that he beat me on the race. Came in second, so I'm honored to say that I followed you. Well, I followed you quite a few minutes behind you, so you definitely win that one fair and square. Just want to know, I heard that you have a bounty about those who beat you get a barbecue. Can I still tag along even though I'm after you?
Absolutely, absolutely. And I do want to just echo all the comments that have been said. This was an opportunity for the community to come together to support our healthcare workers and specifically our public servants that work within our public healthcare system. So again, thank you for acknowledging them and for your support.
Great job, Paul. Thank you so much. And that's all I have, Chair.
All right, thank you very much. That takes us then to item 12D, and that's our Behavioral Health Services Department. Who do we have with us today for that item?
Good afternoon, Chair Simitian and Supervisor Lee. Sherry Terrell, Director with Behavioral Health Services Department. No additional information other than what is written in the report, but we're happy to take any questions.
Thank you, Mr. Rao. The only thing I would take note of is when the agenda comes out this evening for the board meeting next Tuesday, I have a referral in that not only asks for a written report in September, but asks for an oral report at the coming meeting on August 31st about state funding for school-based behavioral health services. And I just wanted to highlight that for you and others today. I'm hoping for a brief oral report at the meeting next Tuesday, as I say, and then a more robust report in writing at the following meeting. My understanding is that the state has something like $400 million headed out to the effort to support mental health in efforts in our schools, with which I have some experience. And, you know, a pro rata share of that would put roughly $20 million at the disposal of our county. And just so you know what I'm hoping to learn, I'm trying to figure out how to whom those monies will go, how they will be used, and in what way they can make the county better off in terms of mental health for young people. It may be early days yet. I haven't been able, frankly, to get a clear understanding of just what that is. I think I understand that the money is not to be used for treatment, that it's for administration and program development, and hopefully might actually facilitate our ability to collect Medi-Cal payments and thereby provide more service to more beneficiaries. But I'm looking for your office to provide a little guidance about, all right, what's coming our way and what's possible. I don't want to miss the opportunity or see it ill-used. Okay.
Yes, we can certainly address your question at the next board meeting. And we were going to ask, because I think the first board meeting in September is September 14th, and our due date has passed for that particular report to be able to be submitted. And so we were going to request if it were possible to come back to the second full board in September and provide a more comprehensive report as per your request.
I'm going to ask you to just give us a written report on the 14th as best you are able, because I don't want time to pass. And I'm going to ask Dr. Smith to accommodate that.
Okay, we will work on that. Thank you.
Great, thank you. And Supervisor Lee, any comments or questions here?
Not really. I think I already spoke it earlier to
Okay.
Terry, just heard regarding the comments from the Behavioral Health Contracts Association, and hopefully we could get that report out.
Got it.
Thank you.
That takes us, thank you, Mr. Rao. That takes us to 12E, which is the report from the CEO of the Valley Health Plan. I have no comments or questions. Supervisor Lee, anything from you?
None from here as well. Thank you.
All right, then let me turn to the director herself and say any comments or questions for your board.
Thank you so much, Supervisor Smitty and Supervisor Lee. The only thing I'd like to talk about for a moment is open enrollment, which starts November 1st for Cover California, and excited to really start moving towards what is a regular enrollment period. We've been in a special enrollment period, and that's really the only thing I wanted to add.
All right, well, thank you for that. I must say, you know, as someone who follows this more closely, I would expect than most folks, I have found it confusing to have the regular enrollment, the special enrollment, and the state response to the federal curtailment, and so on and so forth. So thank you for that. That takes us to item 12F, which is to receive the report from the Emergency Medical Services Agency. And I think I see Ms. Lowther, I do. And I see Dr. Miller as well. And I will just say, as I read the grid, it looks to me like the response times that you know are a particular interest of mine continue to be well above that 90% threshold that's required in all of the reporting agencies. Do I have that right?
Yes, sir.
All right. Then I'm going to take yes for an answer.
Yes, sir.
Supervisor Lee, anything?
No further, thank you.
All right, thank you. Anything you want to share, Ms. Lowther or Dr. Miller?
No, it's been very busy out there, and everybody is doing a fabulous job keeping up with the volumes. So thank you.
I should ask in that regard, Ms. Lowther, does that mean that you are seeing, and forgive me if it's in the materials and I just didn't get to it, does that mean you're seeing either a bump or a return to prior levels after the lower level of calls during the height of the COVID pandemic?
Yes, we are. For July, in fact, we were at about 247 transports per day to the hospitals, and we've even seen a slight increase in August. So the hospitals are pretty busy, and they're really all working very, very hard to get offload times and to get those ambulances back in service. So yes, I would say we are back to pre-March 17.
Thank you. And that takes us to 12G, which is custody health. And I believe Dr. Day is unavailable today, that she's away on other business. But through you, Mr. Santiago, is there, I have no questions today. I don't know if Supervisor Lee does. Is there anything that Custody Health would like to share with us?
No, and thank you for recognizing Dr. Day's absence. She, in her absence, however, she did write a very comprehensive report on all the COVID-related activities, as you have shown interest in the past. And of course, we have Pratima Pandey here available in case you have any questions.
Thank you. Supervisor Lee, you good to go on this one?
Yeah, actually, I do have a question on custody health.
Please.
Given the latest FDA approval of the vaccine, we certainly have heard various outbreaks regarding in our custodial facilities. Question is, has there been any consideration of basically instead of voluntary of actually mandating vaccination to our housed inmates?
I do want to answer that. I
Please.
do not know whether we're able to mandate, but I do want to share that starting this weekend, in partnership with the Office of the Sheriff and the CEO's office, we're beginning a vaccine incentive program. This is in addition to the numbers that are already in the HHC report. So when we come back next month, we will have more numbers to share as a result of the incentive program.
Right, an incentive program is giving more privileges or phone time usage or some goodies like snacks and whatnot, right? That's what you're talking about, correct?
Yes, Supervisor. And basically, it's going to roll out in 2 phases this weekend when the Custody Bureau will receive the incentive packages that include some items from the commissary as well as phone cards. Those will be handed out to those patients who have received vaccinations while they're in our correctional facility. And then that we hope will incentivize, and there is already a vaccination clinic scheduled for the 27th and 28th. And then we have a clinic scheduled on the 3rd of September and the following 2 weekends as well.
Are we giving them the 2-dose vaccines or are we doing the 1 dose?
We have all the options available.
Okay, all right, very good. Thank you very much.
Thank you.
Thank you, Supervisor, and thank you, Ms. Bendy. And I want to go to Dr. Smith, whose hand is up, who has mastered the technology, I see. Dr. Smith?
I wouldn't say mastered, trying to work on it. I wanted to address the question a little bit about mandates. You know, we do have 2 populations in close proximity in the jail, one being our employees and the other being our clients. And we, as the board knows, have begun a vaccine mandate program for our employees. And we do have a significant number of custodial staff who have not been vaccinated at this point. So we are focusing on them at this point. In terms of whether or not we can mandate vaccine for the inmates, at this point, we've taken the position that that's beyond our scope. However, I know legal is looking at it again, and I'm not competent to make a legal decision in it, but maybe Mr. Press could comment about whether we have that option.
Hi, good afternoon. Yeah, I'm certainly circling back with my health and hospital team, but these folks are patients. They do retain the right to refuse care. So I'm trying to think of a scenario where one could, on an involuntary basis, administer a vaccine to a patient against their will. I can't think of a scenario right at this moment. But as I said, we're still looking at the issue, but I certainly pursuing the incentive route seems like a good first step at this point.
Chair, may I follow?
Please do, Supervisor Lee.
Thank you. So yes, Mr. Press, thank you for the explanation. I certainly am a strong proponent of incentivizing. It's always better to do it that way to get voluntary compliance. The idea of having an FDA vaccine, as you understand, is that certain vaccinations is certainly a mandatory. For example, when you talk about your smallpox, MMR, measles, mumps, and rubella, those are actually mandatory vaccines that we already have. And the most recent approval of FDA, I believe, has now elevated the Pfizer vaccine to be in that category for 16 and above. So my question is that maybe this is a question for Mr. Williams, to James Williams, to come back on the attorney research memo, and we could discuss what our next step could be. But thank you very much.
Sure, and I'll just add, when you say mandatory, it sort of begs the question, mandatory as to what scenario. In other words, you can have vaccines that are mandatory for example, service in the military, which again is voluntary, mandatory for attendance at school, which is a little bit of a more unusual scenario in that attendance at school for children is mandatory. At the same time, as you're well aware, there are medical and other religious exemptions available for vaccines. But yeah, we'll circle back with you with a more definitive answer on this question.
That would be great. Thank you very much, Mr. President.
Sure.
All right, thank you. And then we will go to item 12H, which is the report relative to federal health policy and budget landscape. I saw Mr. Margolin's cube somewhere on the screen. Mr. Margolin, there you are. Thank you. What would you like to share with us? And I'm pleased to say that for once, we aren't getting to you with only 30 seconds left. So you probably don't want to take the remaining 30 minutes, but you can be a little bit more paced in your presentation if you like.
Thank you very much. I appreciate the additional time that's available. I will still try to get to the point and make this presentation as succinct as possible. The biggest issue facing the Congress right now is the effort to get this budget reconciliation package, 3.5 trillion, approved. The 3.5 trillion is connected to the 1.2 trillion bipartisan infrastructure package. This is the biggest issue that has an impact on our health programs, and I'll explain which programs and in what way as we go forward. The Senate has already passed with the bipartisan infrastructure package with 19 Republicans joining the Democrats. On the budget resolution, which is the key to getting the 3.5 trillion, the second piece, there were no Republican votes. It was passed on a strictly party line basis, but it did pass. The House of Representatives yesterday just passed its version of a budget resolution after a somewhat intense and complicated negotiation between the Speaker and the House moderates, who wanted a vote on the bipartisan infrastructure plan, the one that deals with bridges and roads. They wanted that to occur now. They didn't want to see it delayed. And the larger Democratic strategy here has been to have the 1.2 trillion and the 3.5 trillion, both programs, both packages, move together. The fear being on the part of the progressive Democrats that if the 1.2 trillion bipartisan plan were to move solo, that certain moderates in the Senate, moderate Democrats, wouldn't vote for the 3.5 trillion. They would take that number down substantially. So there's this fear on both sides about the full package not moving forward, both packages not moving forward. And that's what Speaker Pelosi had to deal with when these 10 House moderates said they weren't going to vote for the budget resolution yesterday unless they got some concession on that point. The Speaker reached a deal with them that had two key elements. She agreed to have the bipartisan infrastructure bill voted on by no later than September 27th, a concession by her, a date certain for that vote to occur. That's the bridges and roads, the physical infrastructure. She also made a concession to the House moderates by saying that on the $3.5 trillion second piece, the reconciliation piece, she was going to encourage and insist on a pre-negotiation with the Senate on their behalf so that the House version that comes up in late September, when all this is supposed to come together, doesn't have provisions that the Senate will never accept. And this is a concern by House moderates that they'll be forced to vote on a $3.5 trillion package when maybe the Senate will only support a $2.9 trillion package. It may be certain provisions that the House Democrats, at least the majority, want, the Senate Democrats will never support. They don't want to cast a vote for provisions that will never make it into the final bill, so this pre-negotiation was the second concession. This all will come together now in late September, according to this new schedule. And on top of that, we have the funding of the government, the appropriations bills, which will probably not be ready by then. So we're most likely to have another continuing resolution at the end of September, which not only has to fund the government, but it has to also raise the debt limit. And because House and Senate Republicans have almost unanimously said they're not going to vote to increase the debt limit, at least that's their position today, there is the real prospect here of a government shutdown in late September, or at least a showdown where the prospect of a government shutdown is raised as part of that showdown. So it's worth noting, as difficult as this may be and as controversial as all of this is, it's worth noting that there is a fairly compelling Democratic consensus to get this done, to get both bills done as part of President Biden's overall package of issues that he wants to succeed on. Evidence for that is not only that you had all 50 Democrats support the $3.5 trillion resolution in the Senate, which again is a ceiling. It's not a guarantee they're going to vote for 3.5 trillion, but they did vote for that ceiling, which is higher than many of them wanted. But after all of the back and forth with the House moderates, Speaker Pelosi got a unanimous Democratic vote on this budget resolution yesterday. So there's strong support for this on the part of the Democrats, even though you're going to see a lot of back and forth and a lot of disgruntled members making statements, there's still this consensus that's emerged. So what are the health issues specifically? There are 5 big health issues in the package currently, and one that House Democrats are trying to insert into the package that's not currently there. Here are the 5 that are in the budget resolution, budget resolutions as they currently exist. New Medicare benefit, dental, vision, and hearing. There's a growing consensus that has to be part of the final deal. There's also an interest in lowering the age for Medicare eligibility, but that has more resistance. Might still happen, but less likely than dental, vision, and hearing being expanded. So that's issue 1. Issue 2 involves the Obamacare exchange subsidies that we've talked about in the past. There's already a new program to enhance those subsidies that lasts for 2 years. This reconciliation package is going to attempt to make that permanent, or at least last for a decade. Nothing is fully permanent, but have it last many more years than the 2 years. And that's a consensus item for Democrats. The third item involves the 12 states that have not expanded the Medicaid program pursuant to the ACA to the new population, the higher income population. Democrats are trying to work out a way through a combination of carrots and sticks to get those states to expand, and there'll be some provision in there addressing the 12 states that haven't expanded Medicaid. There's 2.3 million people who don't have coverage today, and Democrats want to see that they get coverage. The fourth item involves an issue that the president has already endorsed, but it didn't make it into the first round of the reconciliation instructions. And it's the $400 billion for home health care. That's something that President Biden from the beginning has said he wants to see in the final package. It's not there currently. It's certainly on this short list of items that Democrats will try to address. And the last item that is referenced in the reconciliation, in the budget resolutions, but it's unclear how it'll come out in the end, involves drug pricing. There's an intense, and has been for years now, an intense battle over drug pricing. The 2 big approaches that are in these budget resolutions, at least conceptually, one is the issue of giving Health and Human Services Secretary the authority to negotiate drug prices. That's the preference of progressive Democrats. There's also resistance from moderate Democrats doing that. And Senator Ron Wyden, the chair of the Senate Finance Committee, is trying to work out a compromise, which would involve not giving the secretary negotiating power, but creating some kind of benchmark price based on international pricing. That's also controversial, benchmark pricing, but this is going on, this negotiation over these different approaches. One of the reasons why it's somewhat consequential to at least to many Democrats that something on drug pricing be done is they're also trying to figure out a way to pay for this package, to not make it simply more deficit financing. And on the health pieces, Democrats have long thought that a drug pricing reform would generate substantial savings to the federal government, which could be used to help pay for these other healthcare initiatives. So those are the big five in healthcare in this budget reconciliation battle. There's one issue that's not there now, smaller issue, but that House Democrats want to see included, and it involves the Hill-Burton Act, which hasn't been funded for years now, but it's a program created in 1946 for hospitals to provide loans and grants to hospitals for capital projects to in exchange for providing care for the uninsured and for low-income populations. It hasn't been funded for a long time now, but there are a number of hospital systems around the country that took Hill-Burton money and still have this ongoing obligation to provide care for this population. House Democrats, in a bill they introduced called the LIFT Act, would like to see this program refunded, several $1 billion of new funding, so that hospital systems that serve low-income populations could apply for new capital construction money that could impact Santa Clara County. It's something we're tracking on behalf of the county. Unclear whether it'll make it into the final package, but it's something that House Democrats are pushing for. So that, Mr. Chairman, completes my summary of where we are and my outline of what the major health issues are. Happy to respond to questions.
Thank you. I have one question, and then I'm going to go to Supervisor Lee. Mr. Margolin, you referenced among that list of 5 issues floating around the budget reconciliation process, the conversation about reducing the age for Medicare, and just actually a couple of points in that regard. Is there a number that is being tossed out as an age that people are talking about, thinking about, targeting in this effort?
Yes. Most recently, they have talked about reducing it to the age 60 to 60.
Okay. And
there's cost attached to that, but that's the issue. Yes.
And is there, and maybe the answer is yes or both rather than either or, but is that effort largely propelled by sort of a simple desire to make Medicare more available to folks at a younger age, sort of as a standalone, or as an effort to move towards Medicare for all incrementally?
Good question. If you were asking that question of Senator Bernie Sanders, he would say it's transition to Medicare for all. That's the way he frames it. Others would frame it outside of Medicare for all and talk about it as a rational way to make the Medicare program more accessible to more Americans and provide more health care. So there is a Medicare for all context here, and again, that's part of the reason why it's more controversial and why people in Washington think that the dental, vision, and hearing benefit expansion has a better chance of making it to the final package. But I'm sure Senator Sanders and other Senate Democrats are going to fight hard for lowering the age.
Do people see those as a trade-off or an either-or, as you framed it, that some would rather do one and some would rather do the other?
I don't think it's so much a trade-off. I think there's kind of a consensus that dental, vision, and hearing should be done by both sides. And the question is, can you go beyond that? And there are some Democrats saying we shouldn't or can't financially afford to.
Yeah, dental, vision, and hearing is essentially a question of doing more for the same group of people as contrasted with doing whatever we can do for a larger group of people, yes?
That's correct.
Okay, thanks. I that particular piece interests me, and I think it's important. Supervisor Lee, anything for Mr. Margolin before we wrap the meeting?
Yes, thank you, Ms. Margolin. The timing is definitely good now that the 3.5 trillion bill was passed yesterday at the House after weeks of wrangling. So just to make sure I understand, the big deal on that is that that being a bill passed along with the $1 trillion infrastructure bill, since the Senate already passed the 1 trillion infrastructure bill, right? So basically, as far as the infrastructure bill is concerned, all we just need is the president's signature and that bill will become law. Is that correct?
Well, the House would have to pass it. and then president's signature. So the House has not taken it up yet.
Oh, they haven't. I'm sorry.
No, so that was the concession made. The moderate Democrats said, we don't want to wait. The Senate's already passed this. You're right. One more vote from the House onto the president. We have a law.
Right.
The Speaker Pelosi didn't want to see that happen because she's afraid the 3.5 trillion will be left by the wayside if that happens. So that's the tension between the different parties.
Now that the 3.5 trillion is being passed, do you know why we're still waiting for the House to pass the 1 trillion?
Yes, good question. And this goes to how complex this is.
Yes.
They didn't actually pass the 3.5 trillion in terms of a real program. In this budget process, in order to do budget reconciliation, which is the majority vote, simple majority vote, you have to trigger it with a budget resolution. So the House committees could do nothing until yesterday's vote. They weren't legally authorized to fill in the detail. The vote yesterday was the green light to do the detailed work, which they now have a very short 4-week period to do. And we don't know, a lot of the issues I've talked about, it's at a very high level. We don't know what the detail is. There'll be intense negotiations, but that's the distinction.
Right. So basically, it's a $3.5 trillion shell for them to then work on the details.
It's a shell, and it's also a ceiling. They may come back with 3.2, 2.9, 2.8. It's a ceiling and a shell. Correct.
Right. But then, so the idea is that this $1 trillion bill is going to be held in abeyance until the 3.5 actual, filled in.
That's the tricky you've raised, the key issue. Speaker Pelosi yesterday agreed, and they've actually passed what's called a rule in the House to make this enforceable, that this 1.2 trillion is going to be voted on by no later than September 27th. That's now agreed to. So what does that mean? I say voted on, taken up. They could also take it up, debate it, decide they don't have the votes until any further. The Speaker has lots of options here. But in a sense, while Speaker Pelosi didn't want to do this September 27th deadline, it may actually be good for the whole process because these are complex negotiations and people negotiate better with a deadline. And we now have this kind of end of September 27th date for the fiscal 1.2 trillion infrastructure. And it's going to force the other piece to be negotiated more quickly. And we're going to have a very interesting several-day period in late September.
Great. So if that's the case, since we do have the Democrats have the majority of the House right now, and also the Senate in that sense, it's a 50-50 +1. Is it possible that the 3.5 trillion bill could be passed without a single Republican vote?
Yes. In fact, right now, that's sort of required because in the Senate right now, there's not one single Republican for it. And in the House, it was all Democrats. And part of the reason why it isn't just the spending, the president wants to pay for this with new taxes and on corporations and others, wants to change the corporate tax rate. And Republicans are unified that they don't want to support that. So it's going to be Democrat only, has to be. That's why the margin's so narrow and why it's so challenging.
Right, and then now you have the Arizona senator and the West Virginia senators. Those are the ones that we need to make sure they come on board as well, right?
Right. And they've already said they don't want to vote for 3.5 trillion. That's one of the reasons why I say in the end, it's likely to be a lower number because to get Senator Sinema and Senator Manchin to vote for this, it's likely that the number will have to go down. But this is a massive amount of money, so there's room to have it go down and for it still to be a very important and historic package.
Great. Very, very complicated. Lots of gamesmanship, and thank you so much for the clarification. Really learned a lot. Appreciate it. Thank you. And that's all I have, Chair.
Thank you, Supervisor Lee. Mr. Margot, unless you have anything else, I'm going to ask Supervisor Lee to give us a motion to approve item 12 in its entirety.
Nothing further.
Thank you again. Supervisor Lee, can we get a motion to that effect?
Yes, and so moved.
Thank you. We have a motion by Lee, a second by Simidian. We'll ask the clerk to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye. That item passes unanimously. And Madam Clerk, unless there's anything else before us, I believe we can adjourn to our next regularly scheduled meeting on Wednesday, September the 22nd at 2 p.m.
That's correct.
All right. Without objection, hearing none, we stand adjourned. Thank you all.
Have a great afternoon.
Thank you.
Recording stopped.